Hi Anju,
Hello, ma'am. You're
how are
looking
you?
bright, funny.
Oh, I
In
I
yellow.
forgot to tell you to wear yellow today, Basant Pachveed. I did tell
Oh, correct, correct.
Rupali.
Yeah.
I thought she might have communicated. Anyways, you look good.
Thank you. Same to you, ma'am. It's Ratlam Formation Day also today.
Oh, is it?
Yeah,
Foundation Day.
yeah. They, I think, renamed Ratlam from Ratnapuri or something. So they celebrate that also.
Ratnapuri.
Earlier, I think it was named known by the name Ratnapuri. Then they changed it to Ratlam.
Hmm.
So that they call it as Formation Day on Basant Panchami.
That's nice. Very nice. Ratnapuri because it's famous for gold, no?
Yes, yes.
Ratlam's gold is supposed to be pure gold or something like that.
Yes, ma'am.
You're originally from Ratlam only.
No, I am from Hubli,
Oh,
Karnataka.
okay. Who I met from Hubli yesterday in our this thing, Kasturi Hirmat. I think she's from Hubli.
Ma'am was she was my teacher when I was doing my BBS.
Yeah. So she is a good friend now. We keep meeting in AICOG and she was there in our genosis webinar.
And she was there in our last to last session also, ma'am. When you had given a talk on cervical encerclage.
Okay, yeah, that time also she was there. Yes. Hi, Dr. Shishikant. How are you? So I'm looking forward to a good panel. Actually, I'm getting a lot of cough and cold because the weather things are not good. So,
In the morning, I thought I'll not be able to talk. Slowly, the
hmm,
voice cleared.
that's what is happening.
And everywhere there's viral, with conjunctivitis especially.
Well, I took the vaccine also, yaar. I normally take vaccine. I have taken vaccine also. वो जो फ्लू वैक्सीन होता है तो भी लिया.
Uh-huh.
ठीक है, कुछ नहीं कर सकते. We are doing this big conference at Indore, huh?
Yes, ma'am,
8,
in May.
9, हाँ 8, 9, 10th में. सो उसको भी
Yes,
सबको अपन अभी बताते हैं. पर तुम तो
yes,
रतलाम में हो तो आ ही जाओगे.
sure, sure, ma'am.
It's a good conference. It'll be. So 4 minutes more to go. So we have to somebody called Pandit Palas,
Parul,
Pandit and
we tried. I think Rupali also has tried. If she joins, we'll come to know, ma'am. I called up Parul, sir. He said he'll join in another 10 minutes.
okay, and Nikita. Nikita
I
said
think Rupali contacted, ma'am.
okay, fine. So where are you in Ratlam Medical College or you have your own practice also?
Own practice. Actually, I had shifted in between to Bangalore for 4 5 years, then came back last year again
Hmm.
and just started in last few months.
Okay.
Basically for some therapy for my son, then came back, restarted. Let's see how it goes.
I know.
Mallikarjun sir has joined, I think.
Yeah, I was seeing him. Hey Rupali,
Hello,
you
Farah. Hello,
yeah,
everyone.
you came in yellow, you listened to me.
Yes. अरे डॉक्टर अंजुम को बोलना रह गया क्या? मुझे लगा मैडम आपने कन्वे कर.
हाँ, रह गया तो मैं मुझे मुझे ध्यान भी नहीं था, नहीं तो मैं पहले.
ओ ओ माय गॉड. आई थॉट तुम लोग के कॉल्स एक के पीछे एक आए थे ना, मिस्ड कॉल्स, तो आई थॉट
हाँ,
फॉर द कोऑर्डिनेशन ऑफ द येलो कलर. ओके. वेलकम डॉक्टर शशिकांत सर. सर यू आर ऑन म्यूट. आई थिंक आई कांट हियर यू.
yeah.
Good evening, everybody.
Hello, sir.
This is Mallikarjun Kirti.
Hello, sir. This
Hi.
is
Welcome.
Hello.
Rupali, sir. Most welcome.
Hi. Thank
Thank
you.
you for honoring the invite and being here.
Oh, thanks for the honor.
In spite of being a weekday and everyone is busy in their practice, we
Yeah.
you here. Hope we have a wonderful time.
Yeah, it was a busy day for today.
Oh, there comes Dr. Pratik and Dr. Sakshi. Welcome. Pratik, you're on mute.
Hello, ma'am. Good evening, ma'am.
Hello, good evening. Pratik is a very upcoming young
Hare, ma'am.
hysteroscopy and a laparoscopy surgeon, and he's got great skills so far as digital platform, I think, is concerned, right? He's very much into all tech savvy things, which I have heard of. So warm welcome, Pratik. We are waiting for your amazing panel too today.
Lovely
Yeah.
to be here, and welcome to all the faculty as well.
Yeah. Hello, Dr. Sakshi. Warm welcome to you.
Thank you, ma'am. Grateful to be here.
Yes. So we'll just wait for a few of others to join as well, and then we'll start.
Yes.
My co-convener, Dr. Anjum, is a little bit unwell. She's having a bad throat, but I would really love to hear from her.
In the morning, I thought I won't be able to talk. It slowly got cleared.
She's really working relentlessly for gathering everyone and, getting into this mode.
Yeah.
Good evening, Dr. Pandit, sir. Warm welcome to you.
Sir has joined.
Yes. Sir, mute. You're on mute.
Hi, good evening, everybody.
Good evening,
Good
sir.
evening.
Good evening.
Is Dr. Archana, madam?
I'm here.
Yeah, madam is here.
Yeah. She is the brain master of this focus series. We have to see, madam.
Yes, thank you so much.
With
Hi,
God's
Pandit. How are
blessing, will
you?
be an excellent program.
Yes. We're looking forward for that.
So I think the clock is ticking 7:01.
Yes, we can start, ma'am. I think few will join.
Mhm. But we need Dr. Parul for his talk, and Nikita is there.
Dr. Nikita, I have called everyone.
I think Parul sir will join another 5 minutes.
Dr. Nikita, ma'am, has not joined.
Okay. So how is Aurangabad, Pandit?
Yeah, great, madam.
Is it cold in Aurangabad as well?
Yeah, the weather is around 10 to 12 degrees Celsius.
Oh, is it?
Yeah.
We were in Delhi at AICOG. It was 5 degrees. So much
Yes.
fog and cold that we caught the cold from there. And it's going on.
थोड़ा ठंड मुंबई में भी भेज दो, मैडम.
क्या बात कर रहे हो? हमारा तो ठंडी
Here
में
in Mumbai, but
आप
it's
cold
better.
से परेशान हैं.
Never that cold as much as it is in the other places.
Nikita has joined, Dr. Nikita. So
Yeah,
you
hi.
can start off with all the things. Hi, Nikita, how are you? I couldn't see you in AICOG.
I saw you, ma'am.
Oh, did you?
Yeah. How are you?
I'm good. I think escalators, no? While coming, going, people were seeing each other like that.
Exactly. It was a mela, na?
हाँ हाँ, वो कुंभ का मेला होता है, उसमें बिछड़े भाई बहन भी मिलते हैं.
I know.
कई बार जो बहुत सालों से नहीं मिले होते हैं उसमें मिल जाते हैं, और जिनसे रोज मिलते हैं वो नहीं मिलते हैं.
No, but it was nice. It was very nice this year. I thought
Very
it
nice,
was
amazing. It was one of the best because venue was amazing, scientific
yeah.
program, and
Scientific content was very good also.
and hospitality was excellence. And weather was also good. I mean, overall weather was good. Outside was कार में से उतरे, उसके बाद तो अंदर अच्छा ही था.
Exactly.
But
Dr. Nikita, welcome. Hello. I've been bothering you
Hi.
for the last 2 days, so sorry.
No worries, no worries.
क्यों
Welcome.
परेशान कर रही थी रूपाली?
Nowadays, sir, also. मैडम ऐसे ही मतलब कॉल्स तो होते रहते हैं ना, ईमेल चाहिए, फोटो
मैडम मैं बोल रही थी कि मुझे क्या ये हिस्टोस्कोपी में गेस्ट ऑफ ऑनर ये सब कर रहे हो, मुझे लैप्रोस्कोपी में कोई कंटेंट दो ना बात करने के लिए, स्पीकर बनाओ. ये क्या है?
मैंने बोला उसको, रूपाली को, मुझे नहीं पता था कि उसने तुमको ये अभी स्पीकर ही करेंगे नेक्स्ट, उसमें स्पीकर, because I have heard him so many.
conveyed this to madam, and maybe we coming, we are coming up with this laparoscopy webinar also.
अभी तो आज हिस्टेरोस्कोपी है. Yeah, definitely.
ठीक है. But my bachas you have taken today in the panel, I'm very happy. Ankita Bansal has done her fellowship with me. Ajay has done his fellowship with me. So
that's why she thought ki maybe keep you as a godmother
अभी तो suddenly old feeling दे रहे हैं मैम आप बहुत ज्यादा. But 51, so okay.
नहीं, you are not that old. अच्छा, we are doing this conference in Indore. I think I'll just put up that flyer here after my talk, and then you come over. Say 8, 9, and 10. There'll be live workshop as well. Live laparoscopy at Indore.
When? 8, 9, 10th, which month?
May.
Okay.
We are informing 6 months in advance.
6 months कहाँ बचे मैम? 4.
4 ही महीने बचे हैं.
4 ही महीने बचे हैं क्या? Are you
Hello
coming
sir,
to
how are
Indore?
you?
हेलो, हाय निकिता.
How are you sir?
या फाइन. अरे सर क्यों, कहाँ से, कब से शुरू किया तूने?
अभी मैं सबको सर और मैम बोलती हूँ क्योंकि पता नहीं कौन बड़ा है कौन छोटा है.
अरे
इरकाड में आ रहे हो क्या तुम? इरकाड अभी जो 31 को है इंदौर में.
आई एम कमिंग मैडम.
हाँ, मैंने आपका नाम देखा था प्रोग्राम में.
वो क्या है?
ये कुछ
यिरकाड,
इतना
ये दिस इज ए टीचिंग प्रोग्राम बाय यिरकाड फ्रांस.
अरे वाह.
हाँ, इंडिया में शुरू हुआ ना. दे हैव वेरी बिग ऑफिस एंड सेटअप इन इंदौर.
Okay. Send me more info ना.
या आई विल सेंड यू.
Okay.
it's a very big and very beautiful center. I recently visited it.
अच्छा
अंदर बनाया, इंदौर में अरबिंदो में बनाया है, बहुत अच्छा है.
जी.
Very good.
वी कैन स्टार्ट मैडम.
चलो,
Madam,
I think
start. Yeah, we can start now, Doctor.
yeah. आगे 7:05 हो गया, स्टार्ट करते हैं.
जी.
Yes, ma'am.
Tell the Sudeep sir to go live and
So, Diksha, can we have this Diya lightning?
ह्याच्यात माझा कॅमेरा दिसत नाहीये की हा
Okay, very good evening to all the faculties, esteemed faculties. We are really very honored today that you have spared your time today out of the very busy schedule, and all of you are here. And it gives me immense pleasure today to introduce Dr. Archana Baser, Madam. She's a founder and the brain master of this focus webinar series under the AICC RCOG West Zone. She's a renowned obstetrician and a gynecologist in Indore, as well as in all over India. She holds interesting list of qualifications. She's an FRCOG, and she's done remarkable work in women's health as well as medical education. She's served numerous leadership roles. She's been the VP FOXY 2020, the organizing secretary at AICOG 2021 Indore, and she's the chairperson of the ISAR MP chapter currently. Madam is also the fellow representative of the AICC RCOG West Zone. Her dedication and leadership roles and academic excellence has earned her wide respect and recognition. She continues to inspire us in many ways. We are truly honored to have Madam amongst us, and she's also the Guinness Book record holder. Let's welcome Dr. Archana Baser, ma'am. She's also a presidential candidate for the FOXY 2026. And Madam, we are here, all of us up here are here to support you. Thank you also for giving me this great opportunity to be the convener, along with Dr. Anjum, who really has done a great job this time of getting all the panelists together and working relentlessly for this webinar. Over to you, ma'am.
Thank you, Rupali, for the kind words. At the outset, let me wish all of you a very happy Basant Panchami. The goddess Saraswati we celebrate today. And I'm really happy that all of you could join in. It is an effort of Rupali and Anjum to make you all come here, and with just short notice, I think after AICOG it was a very very short notice, they could connect with you and got you here. And today we have very interesting topic, hysteroscopy, dilemmas, and very interesting panel as well. And happy that Dr. Nikita Trehan and Dr. Pandit Palaskar have joined us. They are great friends and good friends and known them since long. And Dr. Parul Kotadwala is going to be giving his talk on hysteroscopy in AUB. We have a very interesting panel where we have chairperson Dr. Kirti, Dr. Parag Deshmukh, and we have our panelists from all over the country: Dipali, Ankita, Varsha, Dr. Shashikant, Amit, Lakwa Sultan, Tanuja, Dr. Ajay Agrawal, Sandeep Sonavne, Nikhil, and Dr. Isha Kriplani. I recently met them, few of them in AICOG as well. And our chief guest and guest of honor, both of them are such superb laparoscopic surgeon. I've seen them operating, and I've heard them many times and very closely interacted with both of them. So can I have CV of Dr. Nikita and Dr. Pandit? So Dr. Pandit Palaskar, I know him from Aurangabad, and he is a pioneer gynecologist, endoscopic surgeon, and done more than 50,000 plus endoscopic surgery, and he and his team have helped 15,700 infertile couple achieving parenthood through endoscopy, IUI, and IVF and ICSI. I think he has several laurels to his kitty: gold medal, highest mark in MD Obs and Gynae, best paper prizes for video presentations. So, Dr. Pandit, we would like you to take the podium, give us some inputs on this webinar and your advice how really more better we can do. So
Yeah.
over to you, Dr. Pandit.
Thank you so much. Good evening, everybody. And thank you, Dr. Archana Madam, Dr. Rupali, and Anjum for inviting me to this August platform. Friends, hysteroscopy and laparoscopy, they play a very important role in today's era of gynecological practice, in general gynec, in infertility. Hysteroscopy has a very important role. We have seen since last 20-30 years, so many advances has happened in endoscopic surgery, and hysteroscopy is not an exception for it. So many new imaging modalities have come, the energy sources have come. So hysteroscopy has revolutionized the rapid progress in science. Friends, hysteroscopy is a very narrow field. The cavity is hardly 3 to 4 centimeter, and as compared to laparoscopy, this operative field is very narrow. So for this, we need to have a highly skillful surgeon to get the best outcome out of that surgery. Uh, to improve the fertility, we need to do hysteroscopy before we pose this patient for infertility treatment, specifically for the IVF in patients with recurrent implantation failure, recurrent IVF failure. We have to do hysteroscopy, and if there is some pathology during clinical examination and the imaging examination, if there is some pathology, we have to do the hysteroscopy, and it gives excellent results. Nowadays, we have office hysteroscopy so that it can be done in the office and without any anesthesia. Patient can come in morning and go in the evening happily. So, hysteroscopy is a very important art that has to be mastered by each and every gynecologist and endoscopic surgery. So, I think today's webinar will be covering all these aspects, how hysteroscopy is helpful in day-to-day gynecology and infertility practice. We have various esteemed speakers and endoscopic surgeons that will enrich the knowledge of hysteroscopic surgery, and it will be very interesting webinar. So I wish very happy learning for all delegates who have joined this webinar, and I wish huge success for Dr. Archana Basir Madam for the forthcoming Foxy candidate in the election, Dr. Archana is a very active academician. She has charismatic leadership qualities, and we need these people to head our organization. So, from my side, I wish huge success for Dr. Archana, and I appeal everybody to support her in her endeavor. So, once again, I wish you all the best, and thank you so much for giving this opportunity.
Thank you, Dr. Pandit Palaskar. Thank you so much for your kind words. As you rightly said, that hysteroscopy is an art which has to be learnt, and correctly said that it is, I mean, it is more challenging than laparoscopy. So I think it is very, very important. And if you see, read, there are more complications with the hysteroscopy because sometimes it's taken very lightly and casually.
Yeah.
So it is very important that hysteroscopy is learnt well, and one should know nuances of hysteroscopy and what can go wrong in hysteroscopy. I'm sure they'll be covering in the panel as well. So thank you very much, Pandit Palaskar, and stay with us for some time. And over to Dr. Nikita Trehan. Dr. Nikita Trehan, again, I have known her, I don't know for how many years now, since long. She has been to our place couple of times to perform the live laparoscopic surgeries, and she has, I think, students all over the country and maybe internationally also. And she's globally renowned gynec laparoscopic surgeon. And what I know Nikita as a very dynamic laparoscopic surgeon, and she's a very good orator as well. And she's a world record holder for largest laparoscopic fibroid removal. And she's a leading academician and live surgery faculty in numerous international conferences. She has publications, CMEs, and workshop. It's always good to have Nikita on our platform. Over to you, Nikita, for your inputs into the hysteroscopy and advice or how really we can do better in the next coming webinars as well.
So thank you so much for that kind introduction, Archana ma'am. And at the outset, I would really appeal everybody to please vote for Archana ma'am for the 2026 presidential election for Foxy, because we need more leaders like her. Regarding hysteroscopy, as rightly said by my previous people, that yes, it is far more difficult than laparoscopy, and two things make it more difficult. One is the instrumentation, the correct instrumentation, getting the thinner scopes, 2.9 mm scope, and also avoiding fluid overload, air embolism. These are very important. I'm sure everybody is going to be talking about it. We have some esteemed speaker like Dr. Parul and the panel which will handle this. But it's also something which we can't do without. Hysteroscope, we have to evaluate the cavity. And today we must understand that the endometrium is sacred. Where, like the ovaries, where once touched, the ovarian reserve can go down. Endometrium, once damaged, you can end up in having Asherman's and the synechiae. So it has to be dealt with respect, because once the endometrium is damaged, the basalis is damaged, you can have a lot of issues. So we have to now also decide whether, suppose you're doing a myomectomy, whether it should be done hysteroscopically or laparoscopically. All those things we will be delving in the webinars, so that the endometrium is protected. Fluid overload, of course, is one of the major issues which comes with hysteroscopy. And whether you're using a bipolar or a unipolar, you can have these complications. So one tip which I would want to give all the youngsters who are watching today is keep your suction on at all times. Let it be 12 liters going in and 12 liters coming out to keep your field clear, but do not cause fluid overload. So continuous suction on is one of the things which you should be using. And also air embolism is something we've all faced. This when we all started our journeys, we've all faced fluid overload and air embolism and all these things. And being a narrow field, hysteroscopy is far more difficult than laparoscopy. So know your limits. If you're going to do a 6 centimeter myoma day one, then you are going to face problems and you are going to get demoralized. So first, initially choose your cases, and recognize your own limits and gradually progress, and know when to do it in two stages and not to become James Bond on day one. So those are the tips which I would like to give the youngsters. And I'm so proud of my fellows. Ajay Agarwal is in the panel today. Ankita Bansal, all of them have done 6 months fellowship with me. And today they are themselves esteemed faculty. So I'm an extremely proud mother today. So thank you so much, Archana ma'am, for making me part of this venture which you're going on for the continued medical education.
Thank you. Thank you, Nikita, for really giving very good tips for hysteroscopy. I think two things which are very important, which you have emphasized, is respect the endometrium and flute. Those are the two very important thing, and other challenges I will be discussed in the panel discussion. And really happy to see that, you must have been seeing that how your journey has taken, like your fellows are now coming as a faculties, and they have been involved in various programs, and so
Very proud of them. They are
and
hard work.
yes, it's hard work and your training and your association with them. So thank you very much, Nikita, for coming to our program. And now, before I give over to Anjum and Rupali for inviting Dr. Parul, I would like all of you who are here to come to Indore for a conference, which is a all vice president conference happening in Indore on 8th, 9th, and 10th May, where we'll have live workshops and we'll have 3 days of good scientific program. So please come over, and I would take this opportunity to support me for my presidential candidature as well. So over to you, Rupali, for inviting Dr. Parul.
Thank you, Archana ma'am. May I introduce the chairpersons for today so that we can get started with the talk. Mallikarjun sir, thank you for accepting the invitation. Sir has been a former NHS consultant at UK, and he has been a visiting consultant at Cloud9 Hospital, Bangalore. His particular area of interest have been labor ward management and gynec endoscopic surgeries. And I welcome you, sir, for today's webinar. Parag Deshmukh sir is our next chairperson. Thank you, sir, for accepting the invite. Sir holds a specialty focus in gynec endoscopic surgery. Here he's practicing in Nashik since and has 15 years of experience. Sir has special areas of interest in advanced gynec endoscopic surgeries and fertility enhancing surgeries, and has been a regular faculty member in various national conferences, especially involving gynec endoscopy work. Thank you, sir, for accepting our invitation. I would like to request Mallikarjun sir to welcome our esteemed speaker today, Dr. Parul Kottawala sir, for the talk. Kindly introduce the speaker and welcome sir to the talk. Thank you, sir.
Mallikarjun, sir, you're on mute, I think so.
Hello, good evening. Can you hear me?
Yes, sir, we can hear you now.
Yeah, okay. So, good evening, everybody. Thanks for giving me an opportunity to participate as a chairperson for this webinar session. It's an honor to welcome Dr. Parul Kotwala, sir. And he doesn't need any introduction, as you can see. He's an endoscopic surgeon and a consultant, senior consultant gynecologist. He's head of the department at Sal Institute of Medical Science, Ahmedabad, and he owns a women's clinic at Ahmedabad, and he's also a senior consultant for Zydus Hospital. He's a former vice president for Foxy, and he's chairman for ICOG, and also he's an India coordinator for New European Surgical Academy and International Adhesion Society. I don't want to take more time. I would like to welcome Dr. Parul Kodwala sir to take over, please. Thanks.
Thank you. Thank you, Dr. Mallikarjun. And I really thank Dr. Archana for asking me to be part of this important webinar. Hysteroscopy has always been very close to my heart. And I've always said that laparoscopy only removes a cut. Otherwise, the surgery inside is by and large whatever we may doing in an open way also. So hysteroscopy makes a quality change. So many surgeries of bygone era have become daycare, like tubal cannulation. Previously, we used to feel sorry for our patients if she had an isthmic blockage. Then submucous fibroid. We used to cut open the uterus to remove a submucous fibroid. Then septum. We used to cut open the fundus, and entire pregnancy subsequently we were worried that rupture may not happen. All these are nowadays of gone, and with hysteroscopy they have all become daycare kind of a thing. So today I will focus more on the role of hysteroscopy in AUB, and let me share my slides with you all. I hope this is visible.
Yes, sir. Just make full screen.
Yes, I'm doing that. Just a minute. Let me sort of set everything. Well, we can always say that hysteroscopy is an eye in the cavity of uterus for abnormal uterine bleeding. As you all know, AUB is a big problem as a gynecologist for us, and more than 10% of our outpatient patients are coming to us for abnormal uterine bleeding. So AUB affects women of all ages. And now we have an internationally accepted terminology. We call it heavy menstrual bleeding, unscheduled or intermenstrual bleeding, and postmenopausal bleeding. An evaluation of uterine cavity in women with AUB is the commonest indication for hysteroscopy. The next common is the infertility. Now, one of my old textbook mentioned that AUB in reproductive age, we should consider it in three aspects. Less than 20 years, primary is hormone, then coagulopathy, and infection, and PCO, the commonest causes. 20 to 40, pregnancy, infections, fibroids, and adenomyosis, and 40 plus, hormonal disturbances and neoplasia. And hence, we used to say that below 20, generally medical management, very rarely DNC, and never a hysterectomy. Three parts were mentioned, only three modes of management were there. For 20 to 40, DNC first, then medical management, and hysterectomy as a last resort. And 40 plus, we used to say first check DNC first, then you can decide either removal of uterus or medical management. All those have changed, and now we have a very detailed classification from FIGO. So the structural changes like polyp, adenomyosis, leiomyoma, and malignancy. These four are structural changes for which AUB may be the presenting symptom. Polyps 100% can be handled both for diagnosis as well as treatment by hysteroscopy. Adenomyosis 15% can be detected on hysteroscopy, and we can offer some form of treatment for these patients. Leiomyoma 10% are submucous fibroids where both diagnosis and treatment can be offered by hysteroscopy. Malignancy or pre-malignancy, you can say 95 plus percentages of diagnosis can be performed by hysteroscopy. So you can see hysteroscopy can make a big impact on handling the cases of AUB when structural abnormality is there. When you go for functional abnormality, of course, coagulopathy is a systemic problem, and here hysteroscopy may not be of great use. Ovulatory causes, again, medical therapy would be the backbone, but endometrial causes, 70% can be diagnosed, and mainly it would be endometritis, which would be the cause of AUB. Iatrogenic, we can diagnose foreign bodies, adhesions inside the uterus. And of course, not defined yet would be malformations of uterus, where again diagnosis and many of the corrections of uterine cavity can be handled by hysteroscopy. So you can see overall 60 to 70% of AUB area can be handled by hysteroscopy. I'll share with you some of the videos right away, and then we will discuss the impact of hysteroscopy. So this is a office hysteroscopy. Nikita did mention about 2.9 hysteroscope, but I have often used even 1.9 as well. So we have three in our armamentarium: 1.9, that is, you can say 2 millimeters; 2.9 or 3 millimeters, which is often called Batochi; and 4 millimeter conventional hysteroscope, which we have been using since years. So here you are guiding the scope inside the cavity. You can see the fluid pressure keeps on distending the passage, and you are in. This way, your dilator might cause some endometrial damage. This way, it is all clean cavity. You look at one corner, look at the endometrium. You may find punctate holes, white dots in the pinkish background. You can see there is a small little polyp, serpentine polyp lurking inside. And then I generally scrape the posterior wall of uterus, which is easy because of antiversion, and see the thickness of endometrium. It can be both atrophic, where very thin endometrium is there, or very thick or moderate. And when you are coming out, you can evaluate the cervical pathologies also, like you can see that polyp is there. Come out and you can see the vaginoscopic appearance. The entire cervix is also seen. So this way, you can complete your entire hysteroscopic examination very fast and very accurately. That brings us to one of the commonest issue leading to AUB, and that is polyp. Endometrial polyps are very common, and small polyps one may disregard, but if they are persistent, many times patient during menses shades the endometrium and polyps also are shaded with it. But sometimes they are persistent and cause AUB. We are not sure whether this is a hyperplasia or polyp. So many times ultrasound cannot give us that diagnosis. We may have to do a saline hysterography, but still hysteroscopy is better because you see them and at the same moment you can remove them. Now, previously we used to grasp the polyp at the base and pull it out. Over the years, I've realized polyps are reasonably sticky. And so you may not be able to take out the entire polyp unless you have detached it. And just by grasping and twisting, you will take out only a part of the polyp. And so you may have to take it out in multiple bites. And this is not a very comfortable situation. So nowadays, I recommend, and I personally perform also, removal of polyp by scissors, freeing it, and then pulling it out. Here you can see I had to take it out in 3 pieces, and only then I could remove it. Now here you can see a beautiful, this kind of picture you will never see when you dilate, a small addition in the center of the cervical canal. And this is how near the base you keep cutting. And once it is freed, you can take it out with a grasper. Only issue may happen is when the polyp is larger than the cervical canal. Then to take it out can be at times a problem. And you may have to dilate the cervix, or else you may have to break it down. Here another case, multiple polyps. You can see flush with the endometrial lining, and keep cutting, separate it, and then take it out. It's little bit sticky also, so you may take some longer time. On the face of it, you may feel, oh, it is such a simple thing. You can take it out easily. Not so easy, but yes, with a little bit of patience. And I generally suggest that the higher polyps you take cut first and then the lower ones, and hold it, stop your fluid, because fluid pressure can also push the polyp again inside. Here you can see, be slow while you are taking it out of the cervix. Otherwise, the cervical canal, when you have used an office hysteroscope, you have not dilated. So it is hardly 3-4 mm, and all polyps would be more than 6 mm when you remove them. And so one has to be slow and stop your fluid so the uterus may contract and push the polyp and help you take it out. The second most common pathology which causes AUB is fibroid. And 10% of fibroids are projecting inside the uterine cavity. You can see here, you may find the illumination little bit poor, and that is because 1.9 mm scope, you can realize after the steel tube how much fibers remain inside. There are no lenses in this, they are all fibers. And the moment you bend a little bit, some fibers will break. And so over a period of time, this 1.9 mm scope, you will realize, has lost the accuracy of vision. Accuracy is there, sorry, but the quantum of vision has reduced because few fibers have broken. So bending has to be avoided, and it is inevitable, especially in tight cervixes, where to look on the sides, you may push a little bit and some bending will happen. Here you can see one submucous and second submucous fiber. Now, there was some discussion about avoiding damage to the endometrial. And I have often now avoided the electric current. Here you can see, you can catch hold of the fibroid, pull it up, and then start twisting. Here you can see what we have done is lifted it. And now we keep twisting, keep on twisting, and you may be able to take out. Small fibroids can be handled in this manner. Here you can see entire base and stalk has come out. And there is a small little crater left behind. Then on this side, this is much larger. So what we do is we put a linear cut. It's not complete resectoscopy. You put a linear cut and then start your resectoscope within this linear cut. So you can see now I am taking out the fibroid. So endometrium will remain hanging at the end of it. And that is how we try to reduce. Another new way of dealing with submucous fibroid is here. I'm sorry, this was performed in a workshop. Okay, I'm so sorry. I think that voiceover cannot be stopped. I'm trying to shut out the voice. Okay, so you can see what I have done is a linear cut there on the center of the myoma. And then what I did was I passed the myoma screw. Now 5 French myoma screw is also available. There it is. What we do is that before we put in a hysteroscope, first we diagnose the fibroid by a hysteroscopy. Then we pass the myoma screw through the cervix inside the uterine cavity. And then we pass the scope. And under vision of scope, we pass the myoma screw inside. Now, in the operative channel, you can pass scissors. So we have now two instruments. One is holding the fibroid, and with scissors, see here, I'm fixing it. And then we keep cutting. Only by pulling, it eludes because fibroid is slightly deeper and held more. So you can see now it is fairly dissected. So we keep cutting with scissors. The fibroid is held by a screw. Directly scissors, if we use, it keeps moving about and we cannot cut accurately. Here the assistant just pushes the fibroid a little bit and then you keep cutting. Another pathology commonly producing AUB is adenomyosis. Here, if your legs are closer to the uterine cavity, adenomyosis legs, you can see here this patient had adenomyosis close to the fundus and lateral wall also. Her prior laparoscopy and hysteroscopy had shown normal cavity. That was 4 years back. And then icon on ultrasound suspected large adenomyosis. And this is how you can see one leg has been dissected. The blood has come out and it would be lined by a dirty endometrium, brownish endometrium. You can see that another leg has been opened up. This is near the left corner. So another area has been opened up. Then we are cutting at the fundus and going towards the right side. You can see these are the dirty endometrial tissue. Now there is another leg which has opened up near right corner. You can see the blood draining through this. And then we expand this to make a bigger area. You can see that again, we are trying to wash away that area by taking the scope closer. And then when we withdraw, you can see this brownish endometrium here that was producing the menses. So open this up largely, and then you may put a Mirena, and then it will prevent the recurrence. So gradually you get the shape of the cavity normal. Here you can see this is the brown patch that is there, and you have got a reasonable cavity. Another big problem for us is endometrial CA, especially in 40 plus women. Obesity, diabetes, hypertension are commonest causes associated with endometrial CA. In endometrial CA, you can have three things. If you can see here, three things are very vital. Punctate calcification. You can see spots of calcification. Fragile endometrium, and third would be distorted vascularity. So if these three things are there, you can see the vascularity, you can see the endometrium, and you can see the calcification. That is very diagnostic and almost 80% accuracy, or 95% accuracy for endometrial CA. But here, this was a focal cancer. And when we tried to bring the scope out, you may find, no, this is not that, just a polyp. You can see only by looking at the polyp, one may feel this is just a polyp. However, this was a case where when we took the scope inside, it was a CA. So DNC can sometimes miss it if your cancer is only on the right side and your scraping is on the left side. You may miss that. And so it is now almost 100% necessary to take an eye-directed biopsy. You look inside, identify abnormal area, and then take biopsy from that area. Intrauterine adhesions. This would lead to generally amenorrhea or irregular spotting. As you can see, somebody must have done a very bad DNC and then infection might have occurred, because however strong DNC you may undertake, this kind of amenorrhea is very, very rare. As a young student, we used to try to scrape the entire uterus very aggressively with a hope that menorrhagia may be treated, because sometimes in books it was mentioned that DNC has a therapeutic value as well. Here, petechial bleeding may happen. You can see complete removal. I mean, there is no endometrium left. This is all fibrous tissue. But sometimes such petechiae may give spotting. Now, this is a very interesting case. Years back, a young girl of 15 approached me. She had intermenstrual spotting since almost 1.5 years. She had approached at least 5 different gynecs. Everybody had given her different hormones with the hope that it is a hormonal thing. and she had recurrence of that. I thought it might be some intrauterine infection like Cox or something. So I requested her that you undergo a hysteroscopy. Obviously, a 15-year-old girl would be reluctant for that. But after a couple of months persistence with the AUB, she agreed. I assured her that your hymen will not be disturbed. So I passed the hysteroscope, and this is what I found: a large erosion of cervix. So it was not Cox at all. And once we realized this erosion used to go for intermenstrual bleeding, through the hysteroscope only I cauterized this by the resectoscopic cautery, and her problem was solved. So sometimes very funny diagnoses which were missed otherwise can be detected by a hysteroscope. That brings us to IUCD. Now this patient had an IUCD left inside, and you can see part of it has got embedded here. In this cases, you may find some clean area also, but part of it is embedded. Don't just start pulling, cut this skin over the, endometrium over the embedded part. Otherwise, you are likely to break your grasper. I have broken 2 graspers in one patient because these IUCDs are very staunchly adherent inside. And graspers have they are tiny instruments. They do not have that strength. And so one has to be careful. And once you grasp the IUCD, pull out both. Don't just pull onto the grasper. Hold it and then entire scope. This is the groove where it was embedded. You can see that beautifully. Now, this is another interesting case. And one of my neighbor, she had AUB since 7 years. And she gave a history of IUCD removal before 7 years. Now you can see the doctor had shown her IUCD, but one part of transverse arm was still left inside. On ultrasound, I saw an echo, so I put in a hysteroscope and found only one part of transverse arm inside. The rest of IUCD was removed by the doctor. And once we removed this, you just hold it and then take both scope and the IUCD out. And her problem was solved. You can see that only the transverse part was left out. Sometimes this is a case of mid-trimester abortion. An unmarried girl had undergone, and then she kept on bleeding. We put in a hysteroscope because on ultrasound, calcified spots were seen in the cavity, and these are the bones that we had to remove. Another big problem, especially leading to infertility also and AUB also, is endometritis. And in India, the COX would be the commonest cause, but otherwise inflammatory reaction to various infections also are there. You can see this kind of multiple micropolyps. We call it brush border. Like a toothbrush, you will find many spicules coming up. These are all micropolyps. As such, they look beautiful, but they cause real trouble to the patient. You can see this area. And long course of antibiotics, and if COX is detected, then of course anti-COX therapy. One more thing, one complication you can say of hysteroscopy is dilatation and creating false spaces. This is more so in young girls and relatively younger women. You can see this is the groove. Somebody had done a dilatation and hysteroscopy and said this is a fibrosis, Escherman. And we found that the actual cavity was much higher, and we could pass the scope inside. Because on ultrasound, I could see good endometrium, and hysteroscopy report was all Escherman syndrome. Patient had infertility and these patients can have abnormal uterine bleeding also. The main thing is that dilatation can cause false passages. This is the area where dilator must have created a space, and then hysteroscopy person kept on opening that area. Products of conception again can lead to AUB. Here you can see it is stuck up. These patients, unfortunately, this one had undergone D&C twice, and yet her problem persisted. And on ultrasound, we could find something in the cavity. And then you can either remove it under vision, or once detected, use a suction and then repeat your hysteroscopy to confirm that everything has been taken out. Hyperplastic endometrium. This is a little bit of a problem. Here, how can you differentiate from cancer? Here you will find large, you can see thick endometrium, but there is an organized area. This is not like cancer where you find calcification or disorganized vascularity. This is the area you can see this thick endometrium is there. And on ultrasound also it is thick endometrium. This is another case of atrophic endometrium. You can see she had infection because you find calcification also in this. It is not just blanched endometrium. So these patients do keep on having petechial bleeding. This is a patient with Asherman syndrome. You can see a tubular cavity, and there is no uterine cavity-like thing, and we could hardly see one cornu on the left side. Then what happened, we brought out the scope and we found that it is here, there is another space. And then we started exploring from that area. This is the area. From here, we tried to cut and open up. And that is how ultimately we could open up the uterine cavity. Asherman syndrome at times can lead to amenorrhea, but generally it leads to irregular bleeding. So once we open up, the entire cavity shape has now become normal. Another issue which has come up of late is isthmosis, the niche in the lower area where cesarean section was performed. Here what happens, the outer part is sutured well, but the inner part is left open. Sometimes people consider that this is because we take the decidua in suturing. I personally feel that in an effort to avoid decidua, you may leave out some part of muscle also, and that may lead to niche formation. And in this, what we do is we cut away this area, so we make a saucerization. So blood does not remain inside. In this case, blood remains trapped inside, and then prolonged spotting would be the complaint post-period. So what we do is we open up this area, make a large saucer kind of a thing, which is flat. And so blood cannot be trapped. But if it is going to, person requires fertility, then we have to either, if it is slightly mobile uterus, we bring it down vaginally, cut away this area and suture it, or else it has to be laparoscopically. I personally prefer laparoscopy because many times bladder is adherent on this area. Vaginally, you may not be able to detect that bladder is adherent, and then you may damage the bladder. And of course, the excess is a limitation in vaginal surgery. Here, cavity is normal. You can see that. And when we were coming out, we found a large isthmosis in this area. So once we are in the cervix, we detect this groove. You can see very well. This is the internal os, and this is where the, not internal os, but the normal uterine cavity. And this area is the isthmosis. It can be detected well by ultrasound. And it has been noted that 40% of patients of isthmosil may complain of abnormal uterine bleeding. The others may be dysmenorrhea, chronic pain, and infertility. That brings us to one big question. The DNC. Way back 27 years back, this paper was published that it is time that we stop doing DNC. Kelly, way back in 1920, 100 years back, described curettage as daily bread of gynecologists, the simplest and safest operation. We now know that when we evaluated critically for diagnostic and therapeutic utility, we realize it is diagnostically inaccurate and therapeutically ineffective. Many pathologies may be missed. So, diagnostic dilatation and curettage, and is it used appropriately? What we found was that so many women, the accuracy was poor. And 50%, only the endometrium was sampled, and in 50%, you get a report that insufficient quantity of material, so no report can be given. So it is not a treatment for menorrhagia, as there is no long-term benefit. Level 2 evidence, and menstrual bleeding returns to previous or higher level by second menstrual period following DNC. And DNC is not completely innocuous. You can see in a large study of more than 12,500, they found perforation, infection, hemorrhage, and unanticipated laparotomy. Out of 18 patients, 8 ended in a hysterectomy. So it has its own problems also. I'm not saying hysteroscopy has no problem, but DNC being not so accurate, not adequate, and yet if we subject the patient to it, it may not be appropriate. So you can find DNC failed to detect intrauterine disorders, subsequently found at hysterectomy, sensitivity only 46%. And negative predictive value is very low, 7.1. So many studies all saying that hysteroscopy is better than blind endometrial biopsy, what we call as DNC. I'll not go into the details, but DNC has limitation. It is a blind procedure. False passage can happen. Inadequate sample 20%, may miss pathology in 50%, need for anesthesia, significant complication rate, and it becomes expensive because patient occupies a bed because of anesthesia. When we look at various intrauterine pathology, you can see hysteroscopy for submucous fibroid, uterine synechia, bicornuate or septate uterus, endometrial hyperplasia, or endometrial CA. It is a much better option than DNC, HSG, or ultrasound. This particular study also showed that sensitivity of hysteroscopy was so good in all polyps, myoma, and hyperplasia. So very high accuracy and very high positive predictive value. Now, I personally feel that over last 20 years, 3 new concepts came into endoscopy. Only 3. One was introduction of colpotomizer to lift the cervix and make hysterectomy safer from trauma to the ureter. Second was introduction of endoscopy in some of the cancers. And third big change was giving office hysteroscopy. Office hysteroscopy removes dilatation of cervix, and so we remove trauma to the cervix in young patients and false passages. Anesthesia is also avoided. In older age, hypertension and diabetes are possible problems for which anesthesia may be a risk factor. And so in an older age, we can help her by avoiding anesthesia. In younger age, we can help by avoiding trauma to the cervix as well as the uterus. You can see this is 1.9 mm hysteroscope, which is thinner than a ballpoint pen refill. This, if we introduce, normally we always say normal cervical canal diameter is 4 mm. So without dilatation, you are easily introducing your scope. The operating sheath, the diagnostic sheath is 2.9 and operating sheath is 3.2. And so compared to regular hysteroscope, it makes a quantum change. And one little problem was amount of light inside. You need a xenon or high quality of light source. Bertocci produced something bending and breaking. So Bertocci brought something in between 2.9 mm, which is slightly stronger and light is better. Cost benefit of office hysteroscopy is it saves hospital stay, reduce medications of anesthesia, no anesthesia, and accuracy in diagnosis and avoids delay in therapy and unnecessary intervention. I personally use only atropine injectable, nothing else. But some colleagues do use prostaglandins intravaginal to soften the cervix. I personally feel that gynec cervix may not respond to prostaglandin. In UK, a fresh guideline has come up that hysteroscopy in evaluating uterine cavity in women with AUB is the gold standard. UK national best practice recommendation is all gynec units should provide dedicated outpatient hysteroscopy to aid management of women with AUB. In the UK, the ambulatory diagnostic hysteroscopy services are well established in most of the NHS hospitals, and most hospitals have one-stop clinic setup for women presenting with postmenopausal bleeding. Way back in year 2000, when I was visiting Birmingham, Professor Janesh Gupta had an office hysteroscopy clinic wherein general practitioners online would take appointment and 2 hours time for 3 days in a week. Every patient would come who has AUB. First, they will go to ultrasound. After ultrasound, they would come to the OPD. Office hysteroscopy would be performed, biopsy would be taken, and histopathology would be performed. So then they would correlate three things: the ultrasound, the hysteroscopic appearance, and the biopsy report. And they have, I think, amassed 1,000+ cases by now. At that time, it was 500+ cases. And you can realize that how accurate hysteroscopy has been. Their matching of biopsy and hysteroscopy was almost 90%. So ambulatory hysteroscopy services would be used as a one-stop see and treat approach. You see whatever and treat simultaneously. Avoid multiple visits for consultation, testing, and treatment. Implement the latest evidence-based practices in a timely fashion. Respond to the needs of the patient and offer patient choice. Prioritize patient experience in managing pain and anxiety. Reduce hospital admission. Minimize the need of OT, but ensure ready availability. One of my ex-trainee once analyzed our cases of perimenopausal bleeding and 52 cases, of which 3 cancers detected, 15 were polyps. The oldest women you can see 97, 83, and 78 years old, all of them had polyps. And we removed the polyps, and all of this elderly lady survived and they have not undergone hysterectomy. 20 had atrophy and 14 had hyperplasia, 2 complex and 12 simple. So you can see 3 cancer and 2 complex. Out of 52, only 5 required a hysterectomy or major surgery. All the rest were saved from a major surgery. So in conclusion, I would say that under vision sampling of endometrium is vital for diagnosis of endometrial CA in perimenopausal bleeding. Office hysteroscopy has the benefit of avoiding anesthesia, hospital stay, and is safer. Office hysteroscopy and directed biopsy may be considered the ideal screening method. And in addition, I add that hysteroscopy is now a must before we subject our patient to any major surgery and to make accurate diagnosis. And most of this diagnosis can be treated simultaneously through a hysteroscopy. So I personally feel that every gynecologist has to learn hysteroscopy well. And now the safety have come up with more and more avoidance of heavy fluids, and we only use saline in most cases. So it has become reasonably safe. and one can attempt for AUB. One may not do a very drastic hysteroscopic surgery initially, like malformation cases or such cases. One may avoid doing a laparoscopy, but one cannot avoid doing a hysteroscopy as a gynecologist. So I personally appeal to all youngsters to latch on to learning of hysteroscopy. Thank you so much for patient hearing.
Thank you, Dr. Parul. I must say this was a precise surgical strike on hysteroscopic procedure. You covered everything and excellent. I agree with a few things. I used to do one-stop hysteroscopic clinic in Aberdeen and Glasgow, and it's very convenient for the patient. And I agree with you that more and more gynecologists should consider conducting those type of clinics in their practice. Thank you very much, and move on to the question and answers, please. Thanks. Any questions, please?
I think this was the most amazing talk after a long time we have attended, especially because it was the teaching was through the videos, and that's the reason why there was a lot to learn. Thank you, sir. Thank you very much for this elaborative talk. And if you have any questions from any of the faculties or any of the attendees, we are most welcome to take one or two. Anyone?
Sir, good evening, sir.
Good evening. Yes.
Sir, I wanted to ask you if at all for submucous fibroid, we ask patient to go for a second look hysteroscopy. What should be the ideal interval?
If you at all decide to do a second look hysteroscopy, 6 weeks should be the ideal gap. Okay.
So what is the reason for,
Generally, I tell them that let one period come through, and after period, I'll do the next hysteroscopy. Because the entire endometrium has to grow back. And if we want to see any small little additions which have occurred, we want to lyse them. So 6 weeks, it would be still soft addition. So you can break with your scope only. When you move it around, you can break those additions, and that is how you can reduce the incidence of addition. This is purely for the fertility cases. For AUB, you do not need a second look.
okay, sir, but
yes, please.
If she have the second menses, she might have means heavy bleeding at that time. What to do then?
No, we are removing the fibroid. So heavy bleeding may not be the problem if fibroid was the cause of heavy bleeding.
And
If
what
there is
if for the
another
big
cause,
fibroid, we sometimes we give a cut and
sorry?
we just wait for fibroid to expel, na,
No, we are removing it. No,
on its own.
I have not shown.
No, if at all it is a big fibroid, and we are we are planning for 2 hysteroscopies.
Okay.
For
So you
first
mean
time,
to
we just give a
say
cut on
that
the.
partial? Okay.
Yes,
Then
sir.
also, I would wait for one period. You can give some medicines to reduce the bleeding, but during the period time, the contractions of uterus will push the fibroid more towards the cavity. So that is why at least
Yes, sir.
one period has to go. And secondly, always measure the myometrial thickness outside the fibroid. So if fibroid is like this, this thickness has to be at least 5 mm. Otherwise, don't do it hysteroscopically. If it is too thin, there would be speculation in that area, and sometimes rupture can happen in that area. Okay. And two-step
Yes,
will have
true,
one
sir.
benefit that after you have removed part of it, due to contraction, this 5 mm will become 7 to 8 mm. So it will be stronger uterine wall. So it would be less problematic for the patient.
Okay, yes. Thank you. Thank you very much, sir, for that detailed explanation. It was a wonderful talk. And thank you for the videos as well. We move on to our
Can
panel.
I just ask one question to Dr. Parul, sir? Okay.
Yes, please.
Just a few. do you use any cervical block or isthmal block? Dr. Ganesh Gupta used to say he gives a block to the isthmus area with a spinal needle. Okay, so that gives.
Did Ganesh say that?
Yeah, he used to give
Huh?
actually.
No,
Birmingham, yeah.
I had spent some time with him. That was 25 years back. And
Okay.
I saw him, and in fact, I got inspired by that clinic that I should also do that. Stores people took 2 years to give me 1.9 mm hysteroscope. They said if it breaks, we have to service it. So in
Yeah.
entire country at that time, they said only 2 people have asked for that hysteroscope. Now, of course, it has become very much prevalent. I personally feel that it is not required. You are not dilating the cervix. And I have
Okay.
been able to, I've done 5 hysteroscopy in virgin girls without touching the hymen. It works. And one biggest talking point to the patient is I tell them, look, you will be able to see inside your uterus. Because if you are conscious, you can also see what I am doing and whether there is any pathology. I can tell them that, look, this is the polyp.
Mhm.
The same thing, ovum pickup, we can ask the patient to see them, do it without anesthesia, and patients really enjoy that. That now we have put a needle inside and we have sucked
Yeah.
the ovum. Something similar. 10% patients do feel a lot of pain, and those who are very anxious, I ask the anesthetist to be as a standby. They are there,
Okay.
but they do not give anesthesia. They have the vein also taken, and we wait. And if it works out, then no need to.
Thank you, sir.
But I share with you one interesting thing. It may be a joke also. Osama, my friend from Egypt, he's also a very good hysteroscopy surgeon. He said that he was in Saudi Arabia and he operated on a royal family lady, hysteroscopic fibroid. It was a polyp, so he cut it. And then he could not take it out because resectoscope also did not work. It keeps on floating. It was not fixed. He said that it will come out during next period. So the family said, it is okay, but you will have to stay here till it comes out.
Okay.
So things can
So
happen.
with a royal. Thank you. Okay.
Since
Okay,
they were
thank
the
you.
royal family, they could afford his stay.
It was not affording. He was scared to his death. If it doesn't
Yeah,
come out, what will happen?
yeah, exactly. Oh, wonderful tidbit.
Hmm.
Anyways, thank you, sir. We move
Thank
on to our panel.
Ma'am, can I ask one question?
Please.
Yeah.
Sir, have you ever used intracervical vasopressin to reduce bleeding for before myomectomy?
I have not used it. No. No, there are many reports, but I have personally not used.
Yes, sir. Many books are saying nowadays that you should use it.
Yes, I mean, vasopressin should work. Especially, it has been noted that pre-menopausal women, you should use it. And the estrogen effect is there, and that may be counteracted little bit. Postmenopausal, it may not be so
May not.
need.
Okay. Thank you, sir.
Okay. So
Thank you.
we can take more questions at the end of the panel as well. Sir is going to be with us. And we know
I'll stay
we
around.
can
Then
ask him endless questions.
in chat box also you can put across question. I'll
Yes.
respond to.
Yes, yes. Please put up the questions in the chat box as well. So we move on to our next panel. We have a wonderful panel from entry to exit, navigating the challenges of hysteroscopy. And we have two very young, dynamic moderators with us today. Can I have Dr. Pratik and Dr. Sakshi's CV, please? Dr. Pratik Naik is very much from Mumbai, and he's a consultant laparoscopic surgeon and gynecologist from Mumbai. He's also done a fellowship with Dr. Sanket Pisat, sir, who is himself also a very well-known, well-renowned laparoscopic surgeon. And he has also done a fellowship under Dr. Deepak Lipacia. Can I have Dr. Sakshi's CV, please? Sudeep, sir?
Yeah,
Yeah, his sir is sharing. Sakshi, just give me a moment. Okay, we have our Dr. Sakshi Kadu. She is a consultant obstetrician and gynecologist at Ashirvad Hospital, Amravati. She's also done her fellowship in advanced gynecology endoscopy under Dr. Nitin Ghorpade, sir, and fellowship in advanced art techniques at Indira IVF, Pune. Her special interest is in fertility enhancing endoscopy surgery and several national and international publications. We move on to introduce the panelists. Can we have the CVs of the panelists as well? We'll quickly go through the panelists, the name and their CVs. Yes, our first panelist is Dr. Dipali Patel, a very dear friend, and she's a consultant obstetrician, gynecology, and a lab surgeon in Kolhapur. She's she's trained as a gynac lab surgeon at Dr. Hafiz Rahman Laparoscopy Center at Kochi. Can we have the next? Dr. Ankita Bansal. She's an advanced lab surgeon, Sankalp Hospital, Ambikapur, Chhattisgarh. Welcome, Dr. Ankita. Next, please. Dr. Sandeep Sonavne, sir. He's got a diploma in gynec endoscopy from France and a fellowship in Mass. 13 plus years in gynec endoscopic surgery, and sir is an associate professor in Nasik, Dr. BPMC. Consultant gynecologist at the Opal Blue Hospital in Nasik, and for international and national publications in gynec endoscopy. Very welcome, sir. Good welcome to you too. Can we have the next? Dr. Nikhil Sonavne, sir, is diploma in reproductive medicine and embryology from Germany. He's a director of the Mauli Hospital, Nasik. Thank you, sir. Thank you for honoring the invite. Dr. Anjum.
Our next panelist, Dr. Varsha Patil. She's the director of Rishabh Nursing Home, Solapur, and is trained in laparoscopy with Dr. Hafiz Rahman. She has also worked at Ashwini Medical College, and she has presented a number of endoscopic videos and cases at various conferences. Welcome, Varsha.
Thank you. Thank you.
Our next panel is Dr. Laka Sultan. She is MS MRCOG. Her MBBS done from Jawaharlal Nehru Medical College, Aligarh, and cleared her MRCOG. She's been currently working as specialist at Haribaksh Government Hospital under SMS Jaipur. Active member of FOXI, IMS, and IFS with special interest in high risk obstetrics and critical care. Welcome, Dr. Laka. Dr. Shashikant Raghuvanshi. He has done his minimal invasive surgery with Dr. Kamini Rao, and he's a consultant gynecologist and obstetrician and infertility specialist, working at his own hospital, Raghuvanshi Hospital, Nagpur, and has been a faculty and a trainer in hysteroscopy workshops. Welcome, Dr. Shashikant. Dr. Tanuja, she is a consultant at Cloud9 Hospital, Bangalore, having a fellowship in minimal access surgery from World Laparoscopy Hospital. I welcome you, Dr. Tanuja. Dr. Amit Galgali has been my colleague from KIMS Hubli, and he has done his DGO from JNMC Belgaum, having a fellowship in laparoscopy trained under Dr. Putambekar sir, with a diploma in office hysteroscopy at Bari. He's a co-winner of Golden Telescope Award at AAGL and co-authored chapters in the book Practicing in Dharwad. Welcome, Dr. Amit.
Thank you, Anju.
Dr. Isha Kriplani, thank you for accepting the invite at the last moment. She's a consultant at Paras Hospital, Gurugram, and she has number of awards to her credit. And she has also been awarded Young Talent Prize at West Zone Yuva Foxy, faculty in Gynae PACE Surgical Program, Paras Hospital, Gurugram, and has number of publications to her name. Welcome, Dr. Isha.
Thank you for having me, ma'am.
Dr. Ajay Agrawal, sir. He's the secretary of IAG Punjab chapter awarded twice as Endoscopic Surgeon of the Year by Economic Times, having a special interest in training and teaching faculty in gynae laparoscopy, and has keen interest in complex laparoscopic procedures. Welcome, Dr. Ajay Agrawal, sir. I'm not sure if he has joined. He had some CME. So I think we are done with the panelist introduction. We can go ahead with the panel discussion.
Yes, over to Dr. Pratik and Dr. Sakshi.
Thank you so much, ma'am, for the kind introduction. I will begin sharing my screen and we'll start the panel shortly. I hope my screen is visible. All the faculty, all the moderators, a very warm welcome. We will begin our panel discussion for today. The topic is hysteroscopy from entry to exit, managing the challenges. So our panelists have already been introduced. So without any further ado, we'll move on to the first case. So our case number 1, with your permission, sir, I would ask the first question to Dr. Mallikarjun Kirti. A 32-year-old woman presents with a history of multiple first trimester spontaneous abortions. Her cycles are regular and her physical examination is unremarkable. Her hormonal profile and coagulopathy screen is negative. She underwent HSG at her local hospital, the report of which is presented here. No other imaging has been performed for this patient. So, beginning our discussion, can this patient be posted for hysteroscopic septal resection, sir?
I think Mallikarjun Kirti sir was the chairperson.
Excuse me for a second.
Yeah.
So, Dr. Deepali Patil, this question will be presented to you. 32-year-old woman, an HSG suggests showing this picture. And our first question for our discussion is, can this patient be posted for hysteroscopic septal resection? Please, Dr. Deepali.
Yes, she can be posted for a hysteroscopic along with a laparoscopy, because first we would like to confirm on the laparoscopy whether it is not a bicornuate uterus. Once that is confirmed, we can go ahead with a hysteroscopic resection.
Any other investigations you would prefer in this patient?
I would also like to do a MRI for this patient so that we can get an advanced idea about the breadth of the septum and its length, so that we can plan the surgery.
Dr. Ankita Bansal, ma'am, is there any other anomalies that we should screen for in such a patient if we get HSG like this?
Yes, on hysterosalpingography, we cannot see the fundus of the uterus. So fundus contour exactly we cannot make out. It can be a bicornuate uterus as well. So we should initially go for 3D scan, in which we can have idea, so that we can post the patient later on.
Yes, ma'am. So a 3D USG will give us an idea of the fundal contour. The fundal contour will be important to plan this surgery in the next case. So as madam said, MRI would also help in the investigation of this patient. On the panel, does anyone have any opinion if there is any other coexisting congenital anomalies that might need to be ruled out in every case?
Renal anomalies.
Yes, Dr.
We need to look to the kidneys to rule out other congenital malformations.
Renal anomalies.
Renal anomalies. But in this case, actually, it is seen that you can very well make out the fallopian tubes, and there is spillage also. So most probably it is a case of septum only. So we can straight away go for hysteroscopic resection and see how much septum we can resect, and then second hysteroscopy we can go for. I don't think in this case we need a laparoscopy with hysteroscopy.
Okay, madam, any other parameters on HSG that may give a clue to the final diagnosis other than the fact
the
that
cervix, because usually in bicornuate uterus, one horn is usually not communicating. So in this case, both the horns are communicating. There is a from lower segment we can very well make out there is a space between the this thing cervix and the fundus.
Okay, thank you, ma'am. So basically, all of this would help us give a clue if there is no other imaging modalities are available. And as Dr. Deepali said, if nothing is available, then laparoscopy is always the option. And then we can confirm whether the uterus is not bicornuate before going for next surgery. So for this patient, a 3D USG was performed, which confirmed the septate uterus, and the patient was posted for hysteroscopic septal resection. Coming to further discussion, this question I will pose to Dr. Amit sir. Since
Yeah.
you studied with Dr. Bitoshi, can you share whether we should perform a septal incision or a septal excision, sir?
A septal incision is what was usually done all these days. Septal excision is what has come now. But there are no studies to prove one is superior to the other. Only in cases where you have a large base, in those cases where after incision you have the septum hanging down, in those cases you can go for septal excision.
So is there anything, a particular size, or is it just something subjective that we have to see while operating?
It is more subjective.
More subjective. So until we get further data, we should continue with whatever we are more comfortable, seems to be the general consensus.
Yes.
Or does anyone have any further opinion or any experience performing septal excision? Moving on.
As far as the HSG picture is concerned, we need to differentiate between the septum and the bicornuate. It is the
Yes.
angle between the two horn which is actually telling us whether it is a bicornuate or it's a septum. And once you put the patient for the surgery, I think we should not ignore the imagings. Like even with the 2D ultrasound, if you do it carefully, you can make out the serosa, and that is also going to tell you something about the septum and bicornuate. And during surgery, of course, during ultrasonography, I would also like to put the Doppler to see the vascularity in the particular septum, so that I should plan the instrumentation during the surgery. If it is without vascularity, I can use Caesar, and that is the preferred modality to be used over the resectoscope or energy sources. But if it is a vascular septum, then definitely I should have electrocautery in my hand.
Definitely, sir. That was very insightful.
Regarding incision or excision of the septum, I also feel if the incision is done in the correct plane, if you stay right in the center, then the need for the excision can be minimized.
And most of the time, these cases are fibrous septum, so they end up opening up the whole cavity like that.
Absolutely.
So most of the cases they don't need excision. It is only in cases of the complete septum also. Even in those cases, if it is quite thin, the moment you cut it, it starts opening up. It gets separated in both the anterior and the posterior walls. So excision as such, I have done excision in only 2 cases till now. That was because one patient specifically asked for it. And then the second case was after an incision, even though I had done an incision, there was some part of the septum hanging from the anterior wall. So it was only in this case that I ended up doing the excision. But rest of the cases till date, I don't think I have actually planned for an excision and then gone in and done an excision.
It is
We
very
can have a
difficult.
biopsy. That is the main added advantage of excision, basically. And we can tell the patient or give a histopathological report to the patient that this was the septum. And
But madam, why do you need a biopsy for that?
no,
See,
many of the times septum means we have to give what procedure was under, because there are so many chances of recurrence of septum and adhesions in the uterine
Septums
cavity.
never recur, madam.
Fibrosis can adhesions can
Fibrosis can
happen.
occur, adhesions can happen. Yes, I agree. But then septums cannot recur like that. It is not something which grows. It is something that is not resolved.
But biopsy we have to give the patients. I mean, sometimes we have.
Basically, we can consider excision in case there is a very fibrous septum which is not retracting, and if we have not been able to exactly get the plane of excision. So, okay, for the benefit of the audience, can you please clarify what are the operative landmarks for the endpoint of surgery? Dr. Varsha, please.
When the mucosa, pink mucosa is seen, and means whitish area or fibrous part is over, we can stop the surgery. Or if we visualize both the ostia at this in a same panoramic view, then we can stop.
So visualizing both the ostia and the panoramic view as well as the vascularity of the myometrium, that will be important. So in your experience, any adhesion prevention strategies, since we were discussing about recurrence and formation of fibrosis, any adhesion prevention strategies after septal resection which have been tried?
Yes, we put the Foley's catheter for 6 hours. We just fill the bulb with 5 ml normal saline, and we keep it like that for 6 hours.
What French of Foley's? Is it a pediatric Foley's, adult Foley's?
8 number.
8 number pediatric Foley's.
Yes.
Okay. Dr. Tanuja, any other adhesion prevention, whether there are these proprietary balloons which are available? So anyone on the panel has any experience with using those?
Copper T was also used initially.
I'm very comfortable using Foley's balloon along with the estrogen therapy to the patient so that it should re-epithelize the endometrium. One point I would like to tell about the excision. See, the reason for doing septal incision or resection is to improve the reproductive outcome. But if the septum, if you want to excise the septum, it is very difficult to do with the scissors. And there you have to use the energy sources. So the patient should not land up in subfertility eventually.
Right.
So that point has to be taken into consideration because you will be destroying the endometrium meanwhile excising the septum. So that point should be considered that we have to improve the reproductive outcome, not to land up in infertility subsequently.
Perfect, sir. So since you were mentioning about estrogen, any role of what is the role of exogenous estrogen? What estrogen to give? How many days to give? Or should we give it with progesterone or only with alone? Can you elaborate for us, sir, please?
I prefer using 2 milligram of estrogen twice daily for 25 days. I couple it with progesterone for last 10 days. I give it for 2 to 3 cycles so that patient should also get proper menstruation. And if and I like to do relook hysteroscopy after 3 months. Office hysteroscopy in such patients. So few may agree, few may not agree because of the financial issue, but I like to do that.
Anyone else has any experience of any second look surgery that is done after septum? Do you do it routinely? Do you do a screening 3D USG and then do a second look surgery? Any further experience on the panel, Dr. Amit?
Usually what I do is after a septal resection, if it is a small septum that we have resected, then I usually just give estrogen progesterone for 2 cycles and then leave it at that. But if I'm doing a large septum, like a complete septum, which I have done in 2 sittings, usually in such cases, I give estrogen progesterone. I have not used any mechanical barrier till date. But like you said, yes, there are some proprietary balloons which are available. But then that has to be kept for a longer duration of 6 to 7 days. And most of the times I had tried it once. What I saw was that the patients were quite uncomfortable with a balloon inside. It is more of discomfort rather than pain, madam, because these are quite small. They're triangular shape. They sit in the cavity, and then there is something projecting out of the vagina. So they're quite uncomfortable with it. So I stopped using it, and I use estrogen for 21 days, 2 mg BD for 21 days, and then follow it up with 5 days of withdrawal bleeding. Usually I do it for 2 cycles, and then I do a 3D.
So
A
it
3D
acts like a
previous
foreign
3D.
body in the uterus, and just like for any other case, it there are increased chances of uterine contractions are there, and that causes pain to the patient also, sir. I
Yes,
have
madam. Yes, madam.
experienced with
Yes,
one
yes,
patient.
yes, madam. Yes, madam. So
But it is
usually
very
what I do is with after hormones for 2 cycles, I do a 3D ultrasound, TVS 3D, and then if I see irregularities, then I go for a relook. And if I see a good, nice, healthy endometrium, I usually don't go for a good look. Only if I suggest, if I suspect adhesions on a 3D, that is only when I plan for a relook in such cases. Because believe me,
Optimal
it is
time
very
for a
difficult. It
second
is
look
very
surgery?
difficult to convince patients for a relook surgery again, even though we do office
Yes, sir,
hysteroscopy in
definitely,
such cases.
It is
definitely.
required only if you are dealing with a very thick septum.
Yes,
Otherwise, you
yes,
actually don't require it.
you
As
don't require it.
And if
as
you are
per
going to plan for IVF or ET, before ET, you have to do the second look hysteroscopy.
Yes, sir, that is a very important point, ma'am. So
Yes.
basically, if the patient is going for IVF, that you would might more go towards second look surgery. Otherwise, you keep it on a SOS basis. Maybe you can do a 3D USG to confirm. Okay. On the next point, you're performing a diagnostic hysteroscopy on a 29-year-old woman. All her preoperative ultrasound, everything was normal. She has no, basically doing for abnormal uterine bleeding. She has no history of any previous surgery. And this image, as noted here, is seen on in the operative scenario. Would you perform any operative intervention? So, an incidentally detected uterine septum, would it be wise to cut? Would it be wise to wait? What would be your ideal plan of management, sir? Dr. Shashikant, please.
Yeah. I think fertility is not a concern at all here. She is with the abnormal uterine bleeding per se, and if other factors have been ruled out and some medical management has been tried, so because we have done hysteroscopy, that means ki you have done the investigations and you have tried some medical management before. So I think that is the only reason that might be causing her bleeding problem. So I would definitely like to deal this problem.
So the USG did not reveal any septate uterus. It did not reveal any abnormality. A diagnostic hysteroscopy was done. So any incidental finding, will you be confident to do or to operate, or would you want to wait
No, no,
for
no.
maybe
See,
a
why
3D
somebody will jump on hysteroscopy, leaving ultrasound or other medical management. So it is prudent that the patient has been tried other modality of treatment. Then only someone will go for hysteroscopy. So in that case, if I find it incidentally also, I will deal with it.
Any
I would
I
like
believe
to
there are two
I have one
aspects
more
to this
opinion.
scenario.
Yes.
So one
Yes,
thing is
Dr.
that
Isha.
without consent, we do not perform a procedure
Exactly.
on the patient. And the
Exactly.
second is that septum does not cause abnormal uterine bleeding. So doing a septal resection in a patient who has, not planned her fertility, and so many patients with small septums have normal conceptions, they have, normal pregnancies and deliveries. So one, without consent, we don't do it. And second, because it does not cause AUB, we don't do it in this scenario.
Any role of whether you would like to rule out a bicornuate uterus before doing any septal excision on an incidental finding with a previous a normal USG not done at a very nice center, no 3D USG done, just an incidental finding of septum. Would you be confident of operating, or would you want to rule out a bicornuate uterus? Would you just want to come out? Dr. Isha, please.
Definitely come out, because one, we don't have the consent. Two, we can't
Consent
put a
is
scope
very
without the consent. And then post surgery, we can do a good 3D ultrasound on an MRI and then confirm whether it is a bicornuate or a septate uterus. And every septum does not require excision, even if the patient wants future fertility.
okay.
But my question is that why won't you take the consent before doing hysteroscopy?
So because
Don't
it
they
was not
require consent for that?
Yeah. The consent here was meant only for a diagnostic procedure, and you don't do any procedures without consent for that. So if you're taken a consent for a diagnostic procedure, you cannot do any operative cases without a written informed consent from the patient. And since your patient is already under anesthesia, she cannot give consent for the next procedure.
Yes, yes, she is right actually. If you are doing only if you are taken consent for only office hysteroscopy, then you have to do only office hysteroscopy, because
Office
in
is
this
without
case you can
anesthesia,
very
so
well
you
see
can.
the hysteroscopic picture is showing that there is the thickness of the endometrium all over is increased. We can see that, means we have to do the septolysis, but we have to take the consent before.
My opinion is surgical modalities are always preferred when the patient is not responding for medical line of management. When you are going for, say, diagnostic, it is not like you are going for diagnostic only. At the same time, you need to inform to the patient that if something is found abnormal, then and then itself we can remove it. That has to be written in your consent, that if septum is
Yes.
there, if polyp is there, if fibroid is there, those things can be removed in the same setting. That will be beneficial for the patient as well. So I think this is not a difficult thing to explain to the patient, and it is quite acceptable to all patients.
You should take the consent simultaneously.
I think regarding consent, really speaking, if there is any consensus regarding there should be a consent for diagnostic hysteroscopy, because many more times, especially in this case, AUB cases, as Dr. Sandeep has told, that we may encounter polyp, fibroid, or anything. And if it is suppose in this picture is with just single small polyp, so what would have done? Probably would have will go for polypectomy. And I think that need to be, whenever we are counseling the patient before going for any sort of hysteroscopy, we need to tell that if there is some lesion which we can tackle in this scenario. For example, if you are going for an office hysteroscopy, we'll tell them that this much is possible in office hysteroscopy. If you are doing it under anesthesia, probably we may go for another alternative also. So I think consent is the most important thing. But I really doubt, is there any something called as consent for diagnostic hysteroscopy? We are just going.
The thing is, most of the times we are doing office hysteroscopy without anesthesia. So problem is, if we are
It is
giving
not the consent
anesthesia,
of. It is not the consent for the anesthesia. It
And
is
for
consent for
office,
the
yes, for
consent for
office
the
hysteroscopy,
procedure.
I think office hysteroscopy is done under sedation or with an anxiolytic drugs. So in
no,
office
without
hysteroscopy,
anesthesia also we can do it. For
yes, we can do it,
1.9
but
mm, we don't need any
yes,
kind of.
Madam, this discussion we would like to keep basically on if it is an incidental finding of septum with no confirmation or non-confirmation of bicornuate, would you operate? I mean, we can discuss. There are going to be other questions where we would discuss consent. Basically, I want a consensus from the panel of whether an incidental finding of septum. No, you don't know if it is septate. You don't know if it is bicarbonate. What would be the ideal thing to do? If you would leave it, would you or excise it?
Actually, whenever there is a septum, whenever we are finding a septum, it is not necessary. We should not embark.
Madam, your voice is getting interrupted.
I think in this scenario, we should wait, just make it as a diagnosis that this is the diagnosis for you and just finish it off. And just later on counsel the patient. And if at all needed, anything is needed, then we can do it in another setting. We can tell the patient.
Agree.
If we have office hysteroscopy set available, it is quite possible that we will get a good quality 3D ultrasonography done in this patient before surgery.
Yes, sir. Definitely. Okay, so I think we'll move on to the next case now. We have to go through everything. So my colleague, Dr. Sakshi, will take over now.
First of all, kudos to all the panelists for brilliant discussion. Let's move on to the next case, which is a rare but could be potentially fatal complication. So I'll read the case out for you guys. Your fellow is performing a hysteroscopic myomectomy on a 42-year-old fit and healthy patient with a 1.5 centimeter meter type 1 submucous fibroid. They are using bipolar resectoscope with 0.9% NS as the media. After 40 minutes of the procedure, you inquire about the amount of saline used. The theater assistant tells you 7 1-liter bottles of fluid have been used. You take over the case at this point. So, moving on, in this case, when should you do a complete fluid deficit calculation? This is a case of fluid overload. So I would like to ask Dr. Ajay Agrawal, when you perform a hysteroscopy, sir, when do you do a complete fluid deficit calculation?
I think Dr. Ajay is not there. This question can be posed to Dr. Sandeep, sir, please.
So it's very common scenario seen in all these operative hysteroscopy procedures. Of course, this is 7 liter is huge amount of fluid that has gone inside. Fluid deficit calculation should be done from the beginning itself. We have to keep on checking what kind
How
of...
often do you do fluid deficit calculation, sir, when you perform a hysteroscopy in a patient?
For each and every case, you need to calculate the deficit. When you know that you are going to do some operative intervention, then this fluid overload thing has to be kept in the mind. And every 5 to 10 minutes, you need to keep on watch on your fluid and the deficit.
Okay, so every 5 minutes.
Yes, 5 to 10 minutes.
Okay. The next question. I would like to ask Dr. Tanuja ma'am, can urine output be included in fluid deficit calculation?
I think Dr.
Is also not there.
Okay, Dr. Laka ma'am, please.
I don't think the urine output should be included in the fluid deficit.
Okay,
It should be only the inflow that we is going inside and the outflow that is coming out.
Okay.
Yes, urine output has to be considered actually.
Why do you say so, ma'am?
You have to calculate everything. I mean, the urine output you have to calculate. Then the fluid coming out you have to calculate. You have to calculate how much fluid has gone intra-abdominally also, and how much is absorbed, because urine output is giving you the idea how much fluid is actually absorbed. You have given 7 liters, but how much has gone out of, means sometimes there is dilatation of the cervix is more, so sometimes the fluid, half of the fluid is coming out of the cavity by the side of the scope only.
Is there any differing opinion regarding this, whether urine output should be used to calculate?
If the patient,
very clear question regarding fluid deficit. Fluid deficit, urine output is not included.
Urine output is not included. We have to calculate only the inflow and the outflow tract. How much fluid we are giving and how much is coming out.
In monitoring the patient, urine output is definitely included, but not in the fluid deficit per se.
I think fluid deficit, I think just as inflow minus outflow.
Absolutely.
The fluid which gets absorbed through this myometrial vascular channels, that is causing trouble. So part of the fluid which is going inside the peritoneum, it is not a electrolyte solution, a non-electrolyte solution like this glycine, it is not going to pose any threat. So normal saline causes fluid overload. It is not associated with hyponatremia most of the time. Of course, with 7 liter of fluid overload will cause, in this case, she will land up in trouble with all these kind of complications. But usually with fluid overload seen with normal saline will not appear with the hyponatremia.
Yes. Dr. Nikhil sir, what is the amount of deficit where you would stop the procedure?
See, generally, if it's
With what fluid?
generally we do use now. I think there is no era of glycine now. We are in the era of normal saline only. So there is no question of regarding glycine or saline. It is always a normal saline which we use. So it's around 1,500 ml to 2,000 ml only should be the target. And I think the practical point which I feel is what the question was, the 7 bottles of 1 liter.
Yes.
So better to use 3 liter saline than a 7 liter, 1 liter saline, because especially in fluid deficit, 1 liter will finish immediately, and by the time changing and everything, so there will be a what we say, there will be a fluid, saline will spill somewhere or something like that. So better to use 3 liter for this thing. Once you start your procedure, tell your assistant or something, or tell that once it is 1.5 liter is over, first alarm should come to me. 1.5 liter over, he should be loud and clear. Then
Is it the same for frail, unhealthy with a patient with comorbidity, sir, or does the value differ for you?
No, so 1.5 liter it's okay for, but see, if it's a frail or comorbid, we need to be, suppose if I say 1.5 for healthy, I can go for 1 liter for the frail or other persons. But 1.5 is first alarm, then 100 ml or 200 ml less to 3 liters. That will be a second alarm to me. And once similarly on that alarm will grow, means suppose it is 1.5 at first alarm, then at around 1,000 at second alarm, and gradually 800 ml and 700 ml. That should be the alarm from my assistant or the other person.
Point noted, sir. Thank you.
Dr. Sakshi, I want to just put something.
Yes.
See, it's a 1.5 centimeter submucous myoma. If somebody using 7 liters of the fluid, so one should look for the other problem also, whether there is any perforation that is causing so much of loss, rather than just going for the fluid deficit. And that too, why somebody is waiting for 1 hour or 40 minutes to calculate the deficit. It should be immediately after the procedure. Okay, how much loss is there?
Do you
So
have a
1.1.
protocol that you carry out in your hospital if such negligence happened by your OT assistant? How do you handle such a situation, sir?
No, 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 no.
Or
Onus is on
it
me.
never happens?
Onus is on me. I cannot blame my OT assistant or somebody else, you know. So that is my duty to look after how much, because as Dr. Pratik said, 3 liter bottle is good enough, you know. You should finish the procedure within 3 liter. Okay. If it is not, then ideally you should see what is wrong. Here I am surprised 1.5 centimeter submucous myoma, 7 liter of fluid is getting
Exactly,
used.
sir.
Why? Where is the fluid going? Is it getting absorbed, or it is getting wasted, or some perforation is there that is putting so much of fluid into the abdomen?
True. But
That is
sir,
the first point.
if the fluid deficit is already so much, so do you look for perforation along with
You
the
know,
procedure?
one
How
should
do
Yeah,
you
you
look for
can.
the perforation in
suspect.
such
One
cases?
should
OT
suspect.
assistant.
See, you know everything is within the field. I prefer to put ultrasound in the operation theater also. You know, if something of that sort is happening, I just put the scope and see what is happening, because one previous section patient I was doing operative, and actually I was seeing there is a cervical stenosis, and actually I was cutting istomosil. That happened with me. You know, so sometimes, you know, you are within the cavity, you are not seeing what is happening outside. So then I realized why so much of gap is there. Then I put the scope and I saw but fortunately there was no other injury, but these things happens. You know, you can
Definitely
be
a
wrong
very
sometimes.
important point to be noted, sir, that we should
Eh,
always rule out perforation also if the fluid deficit is such a huge amount.
With
3 liter
one
bottle
more
is a very good thing.
And
3 liter
because
bottle is a very good thing. One more point which I'll add, especially in a postmenopausal uteruses, which are smaller uteruses as compared to the younger woman, the chances of perforations are pretty high with the even 2.9 or hysteroscope. And another important point is, whatever the fluid management system which you are using, your ear should be on that flow of sound of that this thing. Once
That
it is
will definitely
continuously
come with
flowing,
experience.
that will, if it is continuously flowing, it is not stopping once you are in the uterine cavity. Just wait, stop everything and look up for the perforation. 90% will be a perforation. Just your ear should be there also on the sound of your fluid management system. It is continuously flowing, that means something is gone, because its cavity is almost 2.5 to 3 centimeter. It will hardly accommodate few amount of fluid.
True,
So better to this is something I feel I should share.
So as a freelancer, I would like to put up one point. Every time you will not get Histromat with you. So sometimes some pressure bags and all these things are used. So it is always better to carry 3 liter bottle, because 1 liter bottle, every time you keep on changing, there is high chance that you might put air into the uterine cavity, and that will get sucked up into the heart. That has happened.
It is always a 3 liter this thing, no
Yeah,
1 liter
that's a
carry.
very good dictum. You can waste the rest of the fluid. That is not a
Yes,
problem.
yes. And one more thing which I see, it has happened with one of the fellow also. Same postmenopausal uterus, it was perforated, and the same 7 liter thing, her abdomen was distended. Then we realized that something has gone wrong. So this might
So it
happen.
does
So,
happen. Yes.
so it does happen, and you have to look at patient as a whole rather than some fluid calculation and everything.
This also explains our previous question that in case of complication, we need to go for laparoscopy as well. So these things has to be explained. Even if you are doing a diagnostic, so-called diagnostic scopy, these all things has to be explained to the patient.
Yes.
That's what I was thinking. Is there is a consent for only diagnostic hysteroscopy? Because you may encounter some lesions, you may do some complications. There is always an associated with
Yes, sir.
laparoscopy consent also. I would like to
Thank
ask
you.
Amit sir and everything. So, what about this
Sir, I
consent?
just want to add one point about perforation. Usually, what we see is if there is a perforation, there is a sudden loss of distension that you see. You are pushing in the fluids, but you are not having sufficient distension to continue with your procedures. So that should give you that should ring a bell if you don't see proper distension. You had a proper distension till now, suddenly you lose that distension. I think that should be the first thing that should alarm that there
Excellent
is some
point, sir.
perforation like that.
Definitely.
One more important point, what I would like to say, you should do ultrasound by yourself to see the flexion version of the uterus.
Exactly.
That also takes a lot of time.
Preoperatively.
What
Where
I
you are
have
going.
added to my protocol is if I am not combining laparoscopy with any operative hysteroscopic procedures, I usually do the ultrasound with the abdominal probe, and the procedure is usually done under ultrasound guidance. I think it's quite safe. We are doing most of our MVAs and everything under ultrasound guidance, and I think nowadays every OT has a ultrasound machine in it. You just need a regular, low cost ultrasound also should do that.
Definitely, sir.
And with vaginoscopic approach, even with a full bladder, I think you can do a comfortable hysteroscopic procedure nowadays.
Yes, sir. Definitely, sir. Thank you for imparting your knowledge on us. Next question I would like to ask to Dr. Sultan. Are there any pre-operative measures that you undertake to reduce fluid absorption during a procedure? Dr. Lana.
Yes, preoperatively, we can do a proper assessment of the lesions what we are doing, and during the surgery also we can maintain the pressure. A pressure should be less than the mean arterial pressure, so that the absorption is less.
Yes.
Because if the pressure we exceed the pressure, because we get tempted to exceeding the pressure to improve our visualization, but that has very negative effect on this fluid management, because as much we are increasing the pressure, the channels will open, and there will be more absorption through the
Definitely, ma'am.
channels.
Yes, ma'am. Can I just ask, for the sake of audience, what pressure do you use in your operating room, ma'am, for distension?
It is usually around, I try to keep it around 80 to 100, but sometimes I may have to increase it, because sometimes the visualization is not so good. So at times it is increased, but I usually keep an eye on the pressure and the fluid also, so that it doesn't lead to any danger to the patient.
Okay, ma'am. Thank you so much. Next question to Dr. Isha Kriplani. What is the role of diuretics to prevent fluid overload?
They're definitely useful, specifically in this scenario where so much of fluid has been used. We should give them prophylactically. 20 mg IV Lasix definitely, increases.
Even without the signs and symptoms of
Yes, if so much fluid has
pulmonary.
gone, then even without signs and symptoms, 20 mg Lasix does not cause any harm to the patient, provided the renal status and systemic optimization has been done. So we can use diuretics to have a better and a smoother post-operative recovery.
Thank you. Next question to Dr. Varsha Patil. Is there any benefit of laparoscopic suctioning to prevent peritoneal absorption in such cases?
Yes, definitely. Sometimes if you are feeling that there are chances of fluid overload or absorption during the procedure, and even laparoscopic suctioning may reduce the absorption after during the post-operative period. So it is better to do it if you are thinking that there is so much. You can do intraoperative sonography also to know how much their collection is there in pouch of Douglas, and afterwards you can just do diagnostic laparoscopy and just do suctioning. That will help for post-operative this thing also.
One question I would like to add here, ma'am, since we were discussing about consent, would this procedure, laparoscopy in this case, require consent, or would it come under, emergency procedure that you would go ahead for the life saving for the benefit?
Yes. We can. This comes under. We are doing prophylactically to save the patient's side effects or something because of this procedure. So intraoperative, we can call the relatives and we can tell them that this is happening and there is a fluid overload, or there are chances that the patient may undergo this thing, and she might need ICU afterwards. And if we explain the patient very well, then they can give the consent. In that case, we can do it.
Okay.
I think I would like to ask one question to all the panelists. How many of us have actually come across a patient where we have had a fluid overload? Any of us has seen any cases like that in your own practice?
Yes, sir. Once it was very beginning when the hysteroscopy just started. The glycine was used as a fluid, and one of my senior was doing the procedure, and suddenly the patient went into coma.
Oh.
And she was shifted to ICU, and there was a hyponatremia, and so patient was given hypertonic sodium solution slowly over a period of 24 hours. But the very next morning she got up, she was out of coma, but she had transient blindness also.
Okay.
But that
Spontaneous malgnosis. So.
Yeah, that reduced after 12 hours. That was also gone.
Okay. Anybody else has seen any cases in their practice, their cases?
I have seen one patient in ICU referred as central pontin myelinosis.
Central pontin myelinosis.
Yeah, retrospectively, we got to know these things has happened and correction was very fast to cause that.
Yeah.
So that was a retrospective thing, not very prospective kind of. And one more thing, practically, if the lesion is too big, so I prefer to use monopolar because I feel monopolar is faster than bipolar. So it reduces my operating time. And that operating time is really important whenever you are dealing with fluids.
Yes.
In
yes.
certain
At this
cases, I do
point, I
that.
would like to ask
Because-
the panelists, do you regularly use GnRH analogs in case of fibroids to reduce the requirement of fluid?
No. I usually...
I would prefer to go laparoscopically rather than try to reduce the size and then try to do it.
Yeah. So with the use of GnRH analogs, you will miss the plane of cleavage in your hysteroscopic procedures. So
Yes.
you should be very careful while advocating GnRH analogs. Of course,
that-
the size of a fibroid is big in size, and you feel like you are not able to go inside and operate it. The whole part is difficult to get rid of. Then, of course, GnRH analogs can be given, but be careful in the hysteroscopic procedures that cleavage plane may be difficult to get.
But Dr. Sandeep, that is moreover in laparoscopy. In hysteroscopy, you hardly look for the cleavage plane, no? You just
Particularly in
resect
FIBO
the...
0 and 1 myomas, there is no question of the cleavage plane because they're almost pretty much in the cavity.
Dr. Isha,
I'm
ma'am,
talking about type 2. So if you're doing type 2 myomas, you may not be able to find out the apex of the myoma when you're giving GNR. This has happened in the past in few of our cases. So myoma, it was very difficult to locate the site of the myoma after GNR analogs.
Yes. Dr. Isha ma'am, I would like to ask you, can you continue the procedure for just 5 more minutes in such cases?
That is a temptation. We all have to deny ourselves. We should know when to stop. That's most important in hysteroscopy.
Okay, ma'am. Thank you, ma'am. I would like to ask Dr. Amit sir, what could be the warning signs for fluid overload in this patient?
You mean during the
Apart,
procedure or after the procedure?
after the procedure, sir.
After the procedure, see, there can
Apart
be
from the
asymptomatic.
obvious fluid deficit.
Yeah. Apart from that, if you're looking for hyponatremia or fluid hyperload or overload, basically, if you're using normal saline in such cases, it is more of a fluid overload rather than hyponatremia. Hyponatremia is more common with isotonic solution. I mean, hypotonic solutions.
Yes.
So in these cases, the patient can have breathlessness, headache. Then patients can even collapse suddenly because this is more, they go more for pleural pulmonary edema in such cases.
Yes. So are there any investigations to diagnose or rule out fluid overload in such cases that you do regularly?
Echo? Yeah, regularly, you mean? Actually, frankly, I have never come across a case of fluid overload after hysteroscopy. But sodium, what I feel is if you have a high risk group, like you have an elderly patient who is a renal compromised patient or a patient with cardiac issues, and you expect that the procedure is going to take longer than what you are. If it is going to take a longer duration, in such cases, I think a pre-op electrolyte should be a part of your panel. And any drop, if you are even in asymptomatic hyponatremia cases, a drop of 10 millimoles per liter can be an indication that this patient is going into hyponatremia.
Point noted, sir. Dr. Nikhil Sonawane, sir, what will be the components of post-operative monitoring for such patients of fluid overload?
Just like any other thing, just TPR BP monitoring, but only thing is strict input output chart, which is most important thing. Then saturation and vitals, and if at all electrolytes, if what sir has told, that needs to be done, and if at all some chest X-ray if needed, and 2D echo and everything.
Excellent, sir. When can this patient be discharged according to you, sir? When she's symptomatically better or lab-wise better or both? Or
I
is
think
there
all.
a particular time for 24 hours inpatient?
When it comes to the patient, there is nothing called as symptomatically better or lab better or everything. If patient is better in all senses, she is fit for discharge. If lab is not there, it's not better, wait. If patient symptomatically not better, wait.
I agree with what sir says.
Yeah, that's true. Because litigations are hanging over our head. So
And the
definitely.
gynecologist also has to be better.
I think we all are.
Another point needs to be added.
If-
Gynecologist has to be better.
yes. And I think if you're asking when to stop treating her, if you're following her up with serial electrolytes, if you're doing a correction, I think there is a protocol. Something says that the correction should not be more than 6 millimoles in 24 hours. So it cannot be one day. If your values are below 120, I think it should take at least two to 3 days for the correction to occur. And usually they stop when it reaches, I think, around 130 millimoles. They stop correcting it and then wait for the patient to stabilize on their own.
Definitely.
Thank you, sir. We'll move on to our next case. So the next case is of a 42-year-old patient who presents with a 2-year history of menorrhagia and anemia. She has failed medical management. A transvaginal ultrasound was done, which was showed a 2.3 by 2.5 centimeter type 1 fibroid. She's not interested in any future fertility, but wants to avoid a hysterectomy. My first question to Dr. Isha, ma'am. Any additional investigations you would like to perform in a case of submucous fibroid?
An MRI to do precise mapping or a 3D ultrasound to assess the FIGO grading.
Okay, ma'am. And for us young laparoscopic surgeons, would there be any preoperative classification to classify the complexity of myomectomy? Whether, if it is something that we can really attempt, or should we defer?
We have the step W classification that, measures different parameters and classifies whether it is going to be an easy, moderate, or a difficult hysteroscopic procedure.
Definitely. So I think the bigger challenge would be to find a radiologist who does the LASMAR scoring than actually doing the case. So usually the LASMAR scoring basically tells us whether a first case of submucous fibroid should be done in one stage or two stage. So, but obviously that would depend upon the skill of the surgeon. So should every case of submucous fibroid be consented for two-stage surgery? Dr. Isha,
Depends on size.
Dr. Varsha ma'am, please.
Depends on size of the submucous fibroid.
Something size is something that is subjective. Like I personally would take maybe I can be comfortable doing 1 centimeter fibroid or half a centimeter fibroid in one stage. So is that something that should be individualized for every surgeon, for every patient, or just blanket every patient of submucous fibroid should be consented for two-stage surgery? Dr. Nikhil sir. Dr. Varsha ma'am, you wanted to say something, sorry.
No, means it's not subjective, I think, because once you are trained doing myomectomy, it's usually it's not that it doesn't make much difference for each and every. It's just depends on the location of the fibroid where the fibroid is sitting. If it is at the fibroid anterior wall or at the fundal region, it's quite easier to remove that fibroid. If it is in the posterior wall, then it becomes difficult, and generally after 2 centimeter the difficulties are more, so it should be a generalized sentence. We can say that very well say that after 2 centimeter, or for each and every case you have to take the consent, but the most of the times it is needed only in cases where the fibroid is bigger than 2 centimeter or 2.5 centimeter.
Okay. Thank you for your opinion.
I think it's a individualized thing, and if the fibroid is really big enough, like 4 centimeter, 5 centimeter, you can try JNRH analog and take the consent for the two settings. Up to 3 centimeter, I think we can do it in single setting, and of course the volume of the fibroid is also really important rather than just one dimension or two dimension,
Right.
because that is ultimately going to tell you how much time you are going to take, what energy sources you are using, what technical difficulties you are getting during the procedure. So it is better to take consent. Then patient might say, no, no, sir, I will go for hysterectomy. If you say two settings and two procedures,
Yes, sir.
that can happen.
Convincing the patient for two-stage surgery is also very difficult sometimes.
Yeah, because she has to bear the cost also, right?
She has to bear the
Stay
cost.
hospital and a lot of things are there. So you can decide your own limitations and you can counsel the patient.
Thank you, sir. Sir, for you only, is there any role of simultaneous laparoscopy in hysteroscopic myomectomy? Whether is that something that you would like to do in any patient?
No, see, I can take a consent. This patient is not willing for hysterectomy as far as this case is concerned, right? So I have to do the procedure laparoscopically, hysteroscopically only. So that again comes to the consent and the all counseling part, right? So if I want to go for laparoscopy, then definitely I would think about hysterectomy also simultaneously, right? I have to tell that patient, okay, if I'm going through the abdomen, then I might do hysterectomy if it is not done hysteroscopically.
I think we have already discussed about GNRH analog, so we'll move on. One question to Dr. Amit sir. You enter the cavity and no obvious indentation is noted on the myometrium. What further steps to take? So I personally would call up and yell at the radiologist, but that can't be done everywhere. So sir, can you tell us some, because a reported submucous fibroid, oftentimes there is nothing.
I have faced this situation in 1 or 2 times. Once what I did was I used the ultrasound and tried to, pinpoint the situation, the position of the fibroid. And there was something which I tried in a second case which helped. What I did was I just cut out the inflow. So as soon as the distension comes down, sometimes what happens is the fibroid just protrudes out like that. You can at least make out the indentation of the fibroid there. So I think these are the 2 times which it has helped. And luckily, I have a very good radiologist. So this is what I did in these 2 cases.
Thank you, sir. So basically, reducing the inflow pressure that can help reveal an indentation which was otherwise missed. Dr. Sandeep sir, your next question. After resecting the fibroid, you note brisk arterial bleeding from the bed. So what is the systematic approach to hemostasis? So stepwise, how would you approach hemostasis in this patient?
Yes, sir. Okay, so you have to pinpoint the source of bleeding. If it is identified, you can with your resectoscope or ball resectory, you can coagulate the vascular portion or vessel which is bleeding. And if after doing it also you come across profuse bleeding, then you can take other measures. So before actually proceeding for procedures, you can, if you are operating on a fibroid, you can use vasopressin. That is one part. Second thing is bleeding happens, then you can use your ball cautery. Third thing is if bleeding still continued, then you can use the pressure system. You can increase your fluid pressure for a time being. And if it doesn't get control, then use balloon or other measures like police balloon if you have, or any other pressure balloons.
We can also use drugs like prostadine, PGF2 alpha, and misoprostol. And a good uterine massage also helps in contracting the uterus.
Thank you, ma'am. So I think this question was asked to Dr. Parul. So anyone on the panel has any experience with using vasopressin, either pre-operatively or intraoperatively to reduce bleeding? Dr. Sandeep, sir.
Yes, we do use vasopressin, but you should be very careful. Don't directly jump into the vessel and push it, because it may.
So how exactly do you administer this vasopressin? Is it given in the cervix or
Not
at the
really.
cervicoischemic junction? How do
We
you give vasopressin?
stopped doing interventions in the cervix. We had very bad experiences. Even the local anesthesia introduction into the cervix led to some convulsions in the patients. And then it's a blind procedure. We avoid it. As vasopressin in a standard with the standard protocol, we diluted 250 to 300 ml, one ampoule, and then you can push it around the myoma and wait for some time. See the vitals of the patient. If she's not having tachycardia or blood pressure is not falling, then go ahead with your resectoscope and
So
get it.
you would use a PRP needle or an ovum pickup needle or something like that to insert it directly into the myoma.
Same PRP needle we can use it for the
And you're doing it under hysteroscopic guidance, correct, sir?
yes,
Under
yes,
vision.
yes, sir. Even for cornolectopics, it works very well. For the ectopic part, which is more than 50% inside the cavity, we inject the vasopressin in the surrounding area. Of course, we take help of through laparoscopy as well in the same sitting.
So if we are doing laparoscopy, why not give vasopressin through laparoscopic approach, and
Yes,
then
sir.
proceed with the procedure like how we do for laparoscopic myomectomies? Why not give vasopressin through the laparoscopic approach and then proceed hysteroscopic resection?
For cornolectopics, are you talking about?
For any ectopic,
Okay.
what I'm saying is instead of introducing the needle inside the cavity, if
Why
you are
not
combining
do
laparoscopy along with it, why not give vasopressin laparoscopically?
This plan has to be decided prior, and you have
So that can be done, right, sir?
Yeah.
That can be done.
Yes.
Dr. Pratik, as far as the arterial bleeding during myomectomy is concerned, I would not rely on prostadine and vasopressin and all those things. If it is there, then I would put the hysteroscope. I will try to cauterize it there itself, because then later on, if again it happens, then how to manage, that is the biggest question.
Getting
And
the
it will
patient
take
back into
some
the
time
operation theater
because
is the challenge.
any drug, if you are introducing, if you are injecting or something, you need at least that drug to give its action. It needs at least half an hour. So it's better to go surgically.
Okay. Thank you, ma'am. So one problem, especially with a big fibroid, so how do you keep dealing with multiple chips of tissue impairing vision? Dr. Nikhil, sir. Dr. Nikhil, sir is not with us. Dr. Isha, ma'am, can you please tell us if there are multiple chips of tissue inside, like how do you stop and remove the bits of tissue, or how do you deal with them?
So once the chips start obscuring vision, we intermittently remove our hysteroscope and bring them out with an ovum forceps. And again, I cannot emphasize enough the role of a good uterine massage, which helps in protruding the remaining part of the intramyometrial myoma into the cavity. And it also helps in expulsion of the chips.
For the chips, what madam has said, intermittently remove, because the cervix is already dilated, smaller parts will come out on its own because of the pressure of the fluid which is inside. Another part is you can use ovum forceps also, or even if it for that removing that chips.
Thank you, sir.
There is a tip here. Can I intervene?
Yes.
Yes,
Definitely.
yes.
If you have multiple myomas, remove the posterior one first, then touch the anterior one. So the chips will fall down onto the resected part. If you do the first anterior one,
Anterior, it will block.
then posterior vision will be blocked. Okay.
And we have to push the chips backwards actually
Yeah.
into the fundus where the space is there.
Any experience with hysteroscopic tissue retrieval systems? Has
They are
any?
good for soft myomas, polyps, but they are time consuming.
Also very, very expensive.
Absolutely.
Haven't been able to afford to buy one till now.
Dr. Parag sir, are you with us? Okay. Anyone has any experience with the technique of myomectomy without myoma extraction? I think Dr. Tahir has published some paper about it, but for me, it seems very almost scary leaving the fibroid inside. But has anyone tried something like this?
Many times we do it.
Yes, ma'am.
In case of pedunculated fibroid, many times we go and cut the peduncle, and if it is more than 2 or 3 centimeter size, it will not come through the means immediately. You cannot take it out. But after putting misoprostol, it will expel on its own after some time of period. Like
It doesn't happen always. It doesn't
then
happen
many
always.
times people do that, and if it doesn't happen like that, then we have to do a second look hysteroscopy and we have to cut the fibroid. But then that time it is very difficult to stabilize the fibroid and the fibroid.
Sometimes people they do keep this devascularized portion inside as it is, and they wait
Yes.
for few days to
Yes,
get it.
it will undergo necrosis and it will
But this
completely.
is I
So
don't have any experience with it.
basically, what happens is when we are doing a myomectomy, we don't take out the whole, even if it is type 0 type of this. We try to I'm sorry. Am I audible?
Yes, sir. Yes.
Yeah.
Please
So
continue.
what we try to do is, even though it is a type 01, we try to start taking chips from the surface. So what happens at the end of the procedure? You have smaller pieces rather than one large myoma that is there inside.
Right.
I never done that, but incidentally it happened when I did it for a big myoma and two-stage procedure was planned. So once I did the first procedure, automatically after a few days, the second also came out. So that happened incidentally. I never tried that or wanted to do that, right? So, but sometimes, it is very scary for the patient, if you don't say that, you counsel that. So, something is coming on, they're shouting what is happening. And I was also scared, probably uterus is getting inverted or what, I don't know.
Sir, Dr. Parul told us about this. So, when you do a two-stage surgery, when exactly do you do the second stage? So, is there, Dr. Parul told us it was 6 weeks, so any other dissenting opinion in the panel?
2 cycles.
2 cycles. So, roughly 6 to 8 weeks seems to be the
8
correct.
weeks.
Okay. Thank you, sir. Moving on to our next case.
Can I just ask one question, please? Yeah, this is Dr. Kirti. Has anybody has any experience with myosure? It's an excellent tissue removal thing we use in hysteroscopy in UK. I don't know if any of you are working in a corporate setup.
Operating with myosures.
So recently,
Because,
we had one live demo with myosure.
Yes.
Yeah.
Yes, it worked very well. But then with our routine conventional way of removal of fibroid, it looks more simple to us because we are.
It's very time consuming actually.
Yes.
Okay. I mean, it's expensive, but I think people working
I
in
think the
corporate
cost,
setup
the
can.
prohibitive
Yeah.
cost makes it very difficult, at least
Yes, yes. 5-6
for
lakhs it is.
widespread use in India, sir.
Yes, yes. 5 to 6 lakhs is the cost, I think.
Yeah, I know. Okay. And one more thing I just want to mention about any operative hysteroscopies, especially fibroid or septal resections in UK, we do consent the patient for possible laparoscopy
Yes, sir.
as
Yes.
a routine.
Yes, sir. True.
I think it's just a safe practice, good practice, just to make the patient aware in advance that they may need it rather than
Nowadays,
doing the
it might
laparoscopy.
require
Yeah.
consensual laparoscopy.
It also helps in evaluation of the other factors for infertility. So mainly fibroid and septum are mainly related to this point. So hardly we do purely hysteroscopically.
We'll move on to our next case, sir. Dr. Sakshi.
Thank you.
Okay, let's move on to the next case. I'm sure we have all experienced this situation at least once. A 33-year-old woman came referred from a fertility specialist with a history of repeated failed attempts at passing an IUI catheter. Her physical examination is otherwise normal. She was posted previously for diagnostic hysteroscopy, which was abandoned due to difficulty in negotiating the cervical canal. She is now undergoing diagnostic hysteroscopy. The following images are seen at the level of external os. So, Dr. Shashikant, is there any imaging you would like to do for this patient preoperatively?
Of course, I would like to do ultrasound. Transvaginal ultrasound is a very good modality that can tell you the canal about the canal. What is the curvature of the uterus? What is the flexion, version? All those things are important in this case. And it looks like a narrow cervical opening. So I don't know what is the situation inside because it has been failed. Failed can be because of stenosis. Failed can be because of stenosis. Failed can be because of curvature. Because your catheter might not have passed through it. It might be S-shaped or zigzag. We don't know that, right? So, but the hysteroscopy was itself failed. Then mostly it is because of the stenosis that might have caused problem and it has failed. That is my opinion.
So you would like to do an ultrasound for sure?
Yeah, sure. Of course. And I would like to do hysteroscopy in this case when patient is menstruating. I would like to see from where the blood is coming, and I would like to follow that track so as to enter the cavity.
Dr. Sandeep, sir, what additional risks of the procedure should be explained to such a patient?
Okay, so in case of cervical stenosis, possibility of false passage, perforation, bleeding has to be explained to the patient.
Yes. Would you take consent for laparoscopy preoperatively for such a
Yes,
case?
for us gynec endoscopists, we call our telescope as our third eye and the ultrasonography as a fourth eye. We have to keep this ultrasonography machine in hand during surgery. It will guide us the exact passage while doing hysteroscopy. So yes, that's it.
Okay, sir. Thank you, sir. Dr. Isha, ma'am, what preoperative measures would you use for cervical preparation in such a case?
So we usually give misoprostol 600 micrograms 3 to 4 hours before the procedure per vaginally or sublingually.
Do you use it regularly for all the patients before hysteroscopy or?
No, in patients with history of previous cesareans or where we are expecting adhesions or a difficult negotiation, then we use it.
Okay, ma'am, is there any way to anticipate difficult entry in a patient which you use regularly?
First is history. Patient is giving history that she's had, failed IUIs, failed hysteroscopy. Then on examination, acutely anteverted or retroverted uterus is harder to negotiate the internal loss. And ultrasound, if there is presence of intrauterine adhesions, then
Are
again.
there any other cervical priming modalities you use other than prostaglandin? Because as Dr. Parul said, it often doesn't work on gynac services. So
we are not using laminaria stents because those are not available to us. Other than that, nothing else.
I believe misoprostol does work. I
It absolutely does.
do the it does work, but I use only 200 milligram orally, 2 hours prior to
how
the
much time? 2 hours prior before.
2 hours prior, 200 milligram orally, and I do, and especially in the case suppose the patient has undergone already cesarean section and uterus is retroverted, and in such cases it does help. And again, during putting the hysteroscope in office setting, it also reduces pain to the patient because you get little bit of dilatation so that it become easy to put the scope with the low pressure into the uterine cavity.
It makes the cervical tissue more pliable to negotiation.
Exactly.
But I have used laminaria TEDs in a couple of cases. I agree with Dr. Isha that they are not available here. But anytime you are in UK or any of your friends are coming from UK, I think you should get them from there. They are really useful in cases where I have seen where we could not, misoprostol has not helped. I'm not very comfortable with misoprostol basically for the fact that it makes the tissue more soft. more pliable and more susceptible for injury. So I have used laminar retents in a couple of cases. We try to insert one the previous night, and then next day morning we take up the patient for surgery. So in those cases, laminar retents really help because mechanically they dilate the cervix and they give a better passage. I'm not very happy with misoprostol.
Dr. Amit, for softening, it takes more time. That is why
Use
I give you
yeah, that's why
prior
you use a lower dose for a shorter duration. I
shorter
agree.
time. So,
But
you get the
I have not.
dilatation, but not the softening. So it
Yes.
helps. And
Initially, I have used misoprostol for almost all my cases, sir, for the first 6 months, because I thought that was how it would be useful. Because as a beginner, I wanted things to be easier. Probably it was my lack of expertise or lack of knowledge at that time. But I thought that it is more easier without the misoprostol, and from that time I have stopped using
even if
misoprostol.
somebody is expert, the patient anxiety cannot be taken out.
Yeah,
Her cooperation is simultaneously
yes,
very much required,
yes,
So,
yes, sir. Yes, definitely, definitely, sir.
Thank you, sir. Dr. Nikhil, sir, should you use Hagar's dilator in patient with difficult cervical entry?
I think for cervical dilatation, difficult entry, Hagas dilator, we are not able to identify the internal loss and dilating it with Hagas. I think it will unnecessarily cause issues, means it will cause false entry or this thing. So better to see and go rather than going a blind thing.
So vaginoscopy first and then
Yes,
see
yes.
and
That
enter.
is routinely we go for vaginoscopically
Even
identify.
in patients with history of multiple failed attempts.
That is, I think, mechanical dilatation, except for what sir has said with laminar and tent. This with this Hagar dilatation, I think it causes more of issue than actual help.
Is there a differing opinion on the panel on this?
Instead of
Yes, in cases, yeah. In such cases, we have used like my seniors were there, and I was also there in that case. So we have used ultrasound guided. In ultrasound guidance, we can use a gas dilator using ultrasound guidance. Even if I have seen case in which we were not able to pass the hysteroscope. We tried a lot, but it was not possible. So we did this use Hagar dilator to dilate the cervix under ultrasound guidance. So that did help.
We can also use them under hysteroscopic guidance. So with the
Exactly.
hysteroscope,
You can see the hysteroscope in ultrasound,
yes,
You
and
can
just
dilate.
pass a
One
narrow
more.
dilator next to the hysteroscope, and under vision you can progress your dilator.
When you hold this cervix with the valcellum, the alignment of the uterus with cervix
Exactly.
change. So
Yeah,
I think it's better to go under vision with the help of hysteroscope.
Vaginoscopic approach.
No, if the patient is anesthetized, why are you scared of holding the cervix, right? You
Yes.
can hold the cervix, you can put the ultrasound, you can use the hysteroscope. So lot many things are in straight line.
You can in fact combine all of them together.
Exactly.
Yes. Dr. Varsha, ma'am, I would like to ask you, how do we know when to quit in such cases? I think she's not with us.
So basically, how do you know when is the right time to give up? Maybe there is no enough cervical preparation. Maybe there is no consent for perforation. So, is there a time frame or is there a particular patient where you would like to say, no, I would rather be more prepared the next time than keep attempting? Dr. Amit, sir.
I don't think it is a question of consent, because every hysteroscopic consent will include a chance of perforation there. So it is not a question of consent. I don't know, in a lighter way, I would say if the anesthetist says stop, then we have to stop it.
If I'm in wrong passage and repeated attempts, I'm not
Yes,
finding the
definitely. If
opening.
I'm in a false passage and I see a false
I
passage,
will
I
quit.
have to stop it and then call the patient back after 1 or 2 cycles and then try attempting with a better consent and a better preparation from our end.
I would like to do it during menstruation. It helps.
During menstruation.
It helps.
Yes. Definitely it helps. It shows the track, and your cervical canal also is more open
Dilated.
during
Yes.
menses. Yes. Yes, sir.
Thank you, sir.
And I think for all these cases, whatever surgery we are doing, I'm sorry I have to say this, but I don't think um, we should be doing a pelvic examination for all cases before surgery. Because I see a lot of gynecologists are quite busy. They would do ultrasound, but nobody actually puts in a speculum and has a look at the cervix or the vagina. Because I was called in for a case. They had done an ultrasound, everything was normal. It was a case of infertility. The patient herself was a staff nurse in ICU for the last 7 years. Husband was also a staff nurse. So we did the laparoscopic part. I put in a scope from the top. I saw the uterus, ovary, everything was normal. Then I told the gynecologist who had called me, Madam, why don't you just push the diaphragm above? We'll have a look at the tubes also. So she bent down and then she could not see the cervix at all. She could not see the cervix at all. It was a case of transverse vaginal septum, and they have been trying for kids a long time. There was just one small opening through which she used to have her menses. So it was a case like that. And then we were stumped at that time. We didn't know. I could just feel the cervix from below. From the top, everything is okay. Then there's just a transverse septum there. So then we had to call the case off and then plan everything. And then we did a vaginoplasty for her.
Definitely, sir. Thank you so much.
So putting in a speculum, I think, is the most basic thing. And I think we should do it for all pre-op cases. We should be doing that.
Thank you, sir. We'll move on to our last case now. A 36-year-old woman with a history of 2 surgical abortions done presents now anxious to conceive. She had undergone a diagnostic hysteroscopy previously, where the notes showed a narrow cavity with no ostia seen. She had underwent diagnostic laparoscopy at that time, which showed normal spillage of dye. So an operative image from the previous procedure is attached, and the patient is again posted for diagnostic hysteroscopy. So what is the complication that could have occurred in this patient?
False
Dr.
passage.
Nikhil, sir.
Assurance.
It's a wrong passage.
False passage.
Yes, Dr. Bansal. So yes, it is a false passage that has happened. So how will we, what would help us to differentiate the cervical canal from a false passage? Dr. Laka, ma'am.
Yes, when we are doing following a routine vaginoscope scopic approach, it becomes very easy for us to follow the cervical canal. We introduce our scope into the posterior fornix, and then we slightly retract the scope and find the cervix. And with the mucus coming out through the cervix and the longitudinal rugae which are present in the endocervical canal will guide us to the endocervical canal. Still, but we do offer difficulties and get sometimes this false passage, but yeah, that is a thing that can guide us.
Basically, you have to follow the rugae of the cervix, and that will lead you, that will show you the right way to go many times. So usually when there is a false passage, there is an increased risk of perforation. So what are the warning signs of perforation? I think we had briefly touched upon this in a previous case, but if you could elaborate for the sake of our audience. So what would send alarm bells for perforation? Dr. Sandeep, sir.
Okay. In case of perforation, if you're dealing with the vascular mass, then bleeding will happen. And second thing is sudden loss of resistance.
Yes.
Apart from your fluid level, you will feel like fluid is going inside, but there is no adequate cavities visualized. So these are the signs which will tell us about the perforation.
When you are in
Dr.
endometrial
Ankita
cavity,
how would you minimize the risk of perforation in a case of difficult entry, in a case of false passage? How can we minimize the risk of perforation, ma'am?
Is it for me? Okay.
Sandeep, sir, please.
Okay, so you have to keep on the pressure on the lower side initially. The second thing is identify first, see and go ahead. If you are not able to delineate the anatomy, then don't jump and don't go ahead. Stop for some time. Try to find out the normal cervical passage or internal os levels. If it is going towards blind end, then there is chance that you may get perforation. So then the cases which have underwent some DNC procedures prior. So in those cases also you will see the lot of adhesions inside, and if patient had undergone a hysteroscopy or DNC just 1 or 1.5 month back, you will see the false passage also. So you may follow that path, and ultimately it will lead to the perforation. So I think this case scenarios, clinical examination, ultrasonographic examination, and hysteroscopic examination will guide you.
I
How
think
would
to
you
avoid
manage, Dr. Nikhil sir, how would you manage a case of perforation in this scenario while perforation during entry?
Hey, if you are perforated, better to stop. Wait for a while. Wait. First thing is to stop, identify it, then look for the your fluids, patient status, and you can use other modalities. If you want to go ahead, then go with the help of ultrasound. If then we can negotiate it through the this thing. So better to stop and take a help of your ultrasound before going
Sir,
ahead.
what is your opinion on conservative versus laparoscopy management for a case of perforation?
See, if you're going with the perforation with 2.9 or everything, majority times it will stop. Just like if you are doing a perforation with the Hegas dilator when you're doing your MTP or this thing, generally it stops by its own, because generally we are using handling the gynec uteruses than obstetric uteruses, so they will stop on its own. But if it's more than 2.3, whenever you're using an operative hysteroscopy, then probably yes, definitely you have to look with the help of laparoscopy and identify
Any
this thing.
dissenting opinion in the panel? Anyone who
I
would do
think since
laparoscopy
you're
for
talking
all
about a
cases?
cervico-isthmic perforation, I think you are giving us
Ultrasound is the better.
regarding the bladder. So we should rule out bladder injuries in such cases.
See, if it is cervicoischemic, two perforations should be keep in mind. One is during entry, that is in cervicoischemic region. Second is in the cavity. Cavity is very easy because sudden loss of distension, and sometimes you see something like omentum and all that. So that is a different story. Cervicoischemic, your direction is important where you are perforating, anterior, posteriorly. Anteriorly, you are dealing with the bladder. So it is always a good idea to put cystoscopy, do the cystoscopy simultaneously to see if, because a lot of time bladder is not injured. Because even if you put there, bladder will move away. So it will not cause any problem. It will not create any problem. So why to do laparoscopy, right? So if the if fundus has been perforated and you feel you have used some seizure or energy sources and you are worried, then you can put hysteroscope transumbilically and see what is the status of the perforation, right? You want to put the stage, you want to put it conservatively, you can do that, right?
Right.
So, but a cervicoischemic region, I would like to put the scope into the bladder and check the integrity of the bladder. If it is fine, then don't worry, nothing will happen. It will collapse and it will stop.
Right.
If you are into the region of the uterines, better to do transvaginal ultrasound to see if any hematoma or collection is there.
Exactly.
That you have to see. So the direction you have to see. And another important point, what I feel you should see while putting the hysteroscope, your opening of that canal should be at the 6 o'clock position. So a lot of time our scope is angled. So how we will perforate? You will perforate with the tip of the scope, right? You're going anterior, posterior. So that way we can manage the case.
Definitely, so
Thank
excellent
you, sir.
points.
Sir, Dr. Isha ma'am, so the nature of the instrument causing the perforation, would there be a different management for that if you're using cold instrument versus electrosurgery?
Yes, absolutely. Because adjacent we have the bladder, posteriorly we have the rectum. So if I'm using an energy source, then of course I would like to rule out any injuries to adjacent organs. Whereas if the perforation is just with the tip of the hysteroscope, then the patient can be managed conservatively.
So basically, we are coming to the last question of this panel discussion. So if you wanted to do a laparoscopy, a diagnostic laparoscopy, would preoperative consent be required in a case of perforation, accidental perforation in any operative case? Or should you take consent for laparoscopy in every case? This is the final point.
All
We'll
hysteroscopies should
summarize.
be, explain the need for an emergency laparoscopy, and consent should be taken in all cases because we do not know in which patient complication may occur.
Right. And whether for whatever reason, if consent was not taken, are we justified to
Yes.
put in a laparoscope for a life-saving as a life-saving measure in cases of perforation?
You are. Yes, of course you are.
Okay. So that would bring us to the end of our discussion. Thank you. You have all been a wonderful panel. Thank you for giving so much valuable information to all of us, students. And I hope this was a stimulating discussion for you also. Thank you for giving your time.
Can I ask one question? Has anybody used Sariprime gel for dilatation? Anybody has tried that?
No, no, not.
Only ANC
Only
patients, sir.
obstetrics patients, sir.
ಬರ್ರಿ ನೋಡ್ತೀನಿ ಒಂದ್ 15-20 ನಿಮಿಷ ಕುಂತಾರ ಅಂತ ಹೇಳೋ ಕಡೆ.
So
thank you.
Thank you, sir. Dr. Rupali.
Yes, it gives me
Thank you,
great
everyone.
pleasure.
Thank you so much.
Thank you very much, Pratik and Sakshi. Both of you all have been excellent moderators, and we have really been very much precise, crisp, on time.
Ma'am,
And
it gives a great pleasure to see my students Pratik and
Yes.
Sakshi doing fantastic work in gynec endoscopy, and they both have conducted this session very well.
Our
Exactly.
first exposure to hysteroscope was through
Dr.
Sandeep
Sandeep sir, Dr. Nikhil sir. They have basically taught us laparoscopy, so it is a privilege for us also to ask them.
Fantastic, fantastic. Very good. I mean, this was an excellent moderation and the panelists' input. We are really honored that all of you esteemed panelists really accepted the invite at such a short notice, and all of you are there here. Thank you very much. Superb. Dr. Parul Kutarawala sir, also excellent talk, great videos. And we thank our chief guest of honor, Archana Baser ma'am had to leave for some emergency, so she's not here. Thank you each and every one of you. Dr. Nikita Trehan ma'am also, Dr. Mallikarjun sir, everyone. We are looking forward for more such interactive webinars, and we'll keep you posted. And we would like you all to be a part of this webinar anytime when we call you, even for a laparoscopy one, everything, because the inputs which all of you have given and the systemic order by which the questions were asked, just fabulous. A lot to learn. Even at this stage of my life, I'm learning. Thank you so much, all of you.
Thank you, ma'am. Thank you all.
Thank you very much.
Yes.
Thank you.
Thank you and good night.
Bye-bye.
Bye.
And so the work backstage flawless. And thank you, my convener Rupali. And yeah, what made it more very interesting is also a touch of humor from all the panelists. So we really enjoyed this panel discussion a lot.
And thanks to Pharmed, our partner, because of whom we are able to do this.
Yes.
And Sudeep sir, who was behind all this coordination, sending of the links, mails, everything.
So I'm putting in a word that Archana Baser ma'am will be contesting for the election year 2026 for Foxy President. Request you all to support her.
Thank you so much, ma'am.
Thank you so much. Thank you.
Good night. Good night to all of you. Bye.